All right, so starting off with the endocrine stuff today, I was informed that you guys have covered everything in endocrine except for diabetes. So if I start with diabetes, then we don't cover anything else until the following week. So comedy of errors, unfortunately, just how it is. Anyway, diabetes is so important. Lots of people got the diabetes, so I think it's good to talk about it first and then go from there. Raise a hand. Who says diabetes? No? Okay, good. Some Wilford Brimley fans, Cocoon fans in the back? Okay. Just curious, just a straw poll. Anyway. All right, so glucose homeostasis. We've covered this quite a bit. I know I was there for physio, I think. So I know you guys know at least a little bit about this, right? Basically, we know glucose providing a lot of energy for our body day to day. It's also a lot of, it's a precursor to lots of things: amino acids, lipids, nucleic acids, all kinds of good stuff. And so we're going to find that there's some dysregulation here. What's kind of the issue with diabetes? Glucose intolerance. And what else? What about like a type 1 diabetic? Insulin production, right? So again, it's important to keep those factors in mind because do you see a type 1 diabetic with a whole lot of glucose intolerance? Not really, because again, their issue is they're not producing enough glucose, right? Do you see a type 2 diabetic with a problem of producing insulin? Yes, you can. You can wear out your pancreas, right? You only have so much insulin you can give in a lifetime. And so you can actually wear that out. So with the type 2 diabetics, you're going to find there's a little bit of a blend there where their main problem is glucose intolerance plus some degree of insulinopenia, right? So they're going to have a decrease in the amount of insulin that's able to be released over time. So we'll look at some graphs and kind of look at that. Glucagon is going to be playing a big role here as well, because what does glucagon typically do? Raises blood sugar by doing what? Stimulates gluconeogenesis by performing glycogenolysis, right? So we're stimulating the breakdown of our glycogen, which is kind of our energy storage, producing new glucose primarily where? Yeah, the liver is a big place we're seeing a lot of gluconeogenesis, right? So that'll be really important. And then where does the glucose normally get taken up into? Yeah, so a little bit's going to the liver, but a lot of it's going to places like the muscles and all kinds of other tissues. But the muscles are going to be a big place where we're going to see a lot of glucose intolerance develop there. So we're going to see that when we're dealing with diabetes, we can do things like replace the insulin, but that doesn't deal with the baseline problem for a lot of people, who is the insulin intolerance, or I'm sorry, the glucose intolerance. And so what we're going to see is that a lot of the drugs we're going to use are going to be things that will either try to increase insulin release, because we can overcome glucose intolerance by giving more insulin. However, another thing we can try to do is try to sensitize the body to the insulin that we're already producing. Okay, so we're going to look at some modalities to kind of try to manage that. Anyway, why is diabetes a problem? Are patients already sweet enough as it is? Not usually. Right, so this really kind of hastens the onset of a whole lot of metabolic complications. So having all that glucose around is not a good thing in the blood, because a lot of it gets oxidized. We can form things like free radicals and reactive oxygen species. We can hasten things like cardiovascular disease. We can see things like damage being done to the neurons over time. So that develops into what? Diabetic neuropathies, right? What happens to the kidneys? All that glucose coursing to those glomeruli. Shreds them down, basically, right? So you get this nephropathies that occur over time. So we're likely to see this kidney damage that happens over time. Again, because you got to reabsorb all that glucose, but guess what? There's only so many transporters there. What happens to that extra glucose if it doesn't get reabsorbed? Pee it right out, right? That's how we were able to test for diabetes in the first place. You saw this really sweet urine that was being produced there. And so we can also see things like a lot of microvascular complications, as we kind of alluded to, but like the retinopathies that can happen there. So lots of different metabolic complications related back to having too much glucose in the serum. We want to get rid of that. We need to get it into the cells where they belong, essentially. So some of the things to help with diagnosis for diabetes, things like the polyuria, polydipsia, polyphagia, those are kind of the triad of symptoms you kind of look for in a lot of patients. Certainly that we're going to be looking at things like resting blood glucose. We're going to be looking at things like impaired glucose tolerance by doing glucose challenge tests to kind of see like how they respond to a bolus of glucose. Similar to what other patients do we see do that? Who do you give glucose tolerance test to? Pregnant patients, right? So we give an oral glucose challenge to pregnant patients to see if they were developing gestational diabetes, right? So we can do this here as well. And then look at hemoglobin A1c. What is that? Yeah, usually like an average blood glucose over the past 3 months by looking at the hemoglobin that is normally transporting a lot of that glucose there. So again, you're looking for something like anything greater than 6.5 would be indicative of something like diabetes, right? So again, lots of ways we can do this, lots of laboratory tests that go into this. Now, type 1 diabetics, they are going to be the minority of patients. However, they are going to require exogenous insulin for survival, right? So what's kind of happening with a type 1 diabetic? Why are they insulinopenic? Yeah, basically autoimmune destruction of the pancreatic beta cells, right? So the beta cells, what comes out of the alpha cells? Yeah, you see a lot of glucagon coming out of the alpha cells. The beta cells, however, are going to be targeted by the body's own immune system. You see destruction of these cells. Is there any way to get those back? No, once they're gone, essentially. So basically, they require exogenous insulin to replace this. If they don't have it, they're going to die, right? And they usually will develop what if they don't have that insulin? Diabetic ketoacidosis, right? DKA is what they can develop there. So again, what's the cure for diabetic ketoacidosis? Lots of insulin, right? So again, this will make more sense, especially when you talk about in the ER, you talk about DKA a little bit later on. You can have a type 1.5 diabetes I talked about before, where you can have a latent autoimmune diabetes in adults. Not super common, but can happen. However, the majority we're going to run into is a type 2 diabetes, 90% of those patients. And now, do all of them require insulin? No, especially not initially, but a lot of them do go on to require insulin at some point because that'll be kind of the ultimate therapy for a lot of these patients. But we'll look at some other meds that can be utilized to try to prevent that from being needed in the first place. We'll look at a lot of drugs that are trying to sensitize the body to the insulin that it is already producing. So anyway, certainly the gestational diabetes we've mentioned, and then also what we call an impaired fasting glucose, which is basically kind of that pre-diabetic sort of stage where we're kind of getting to a point where they're showing signs of glucose intolerance or kind of heading in the wrong direction. They could be at risk for developing further diabetes. So, as you mentioned, for as far as morbidity and mortality goes, a lot of type 1 diabetics tend to eventually succumb to things like renal failure versus type 2 diabetics, more like the macrovascular complications like cardiac disease, things like that. And certainly risk factors for type 2 tend to be a lot of things that we can modify, things like diet, things like ethnicity we can't really change, but lifestyle is going to be a really big one here. Certainly, though, with type 1s, we think more like genetic predispositions and things like that. So, getting into the actual issues here, kind of get into pathophysiology. So some of this is a little bit of a rehash from physiology. Some of this we'll probably get in endo as well, but we'll kind of cover here briefly, just so we're all on the same page. But we mentioned our alpha cells. These are going to be where we're seeing a lot of glucagon being released here. We said glucagon's main goal is to do what to blood sugar? Raise it up, right? So we're going to see glycogenolysis, we're going to see gluconeogenesis coming out of the liver, so we're going to see increased blood glucose. On the flip side of that, we're going to have our beta cells, which are mainly producing insulin. What's C-peptide? Remember what that is? Remember, so there's proinsulin. Normally our pancreas is secreting proinsulin, which will eventually get cleaved into insulin and C-peptide. So we're going to look at that in a second. But basically, we're going to see the beta cells are primarily associated with that. Insulin, once it gets interacting with the cells, that glucose then gets stored into the cells. What can that glucose then get stored as eventually? What does it do in the liver? So if glucagon stimulated glycogenolysis and gluconeogenesis, then insulin should stimulate glycogenesis, or we should be generating glycogen, because again, that's where we're storing energy at in the long term for these patients, right? So think about that. Certainly somatostatin can come out of some of these cells as well. Somatostatin we also know as, we mentioned it in the GI section, I believe. Triotide, yeah, so that's a kind of our synthetic form of somatostatin that we can produce. Anywho, so looking at, say, like a normal patient versus a type 2 diabetic, what you're going to eventually see is that normal alpha cells are going to be secreting glucagon, normal beta cells secreting insulin, everything is right with the world. However, once you kind of wear things down over time by having this kind of chronically high glucose your body's trying to deal with, you're going to find that there's alpha cell dysfunction where you're actually secreting too much glucagon, right? And then fewer beta cells are going to be available. They'll eventually kind of die off, and it'll be secreting an insufficient amount of insulin. Okay, so it's really important, especially with some of the newer meds we have for diabetes, to remember that the problem with a lot of these diabetics as well is not just a lack of insulin, it's also they have too much glucagon around, which is going to be driving up our blood glucose. So some drugs are going to be directly affecting that. And then, what do you think is like an event that normally suppresses glucagon secretion? What normal event we might do like 3 times a day? Eat, yeah, right. Because again, once you're having new glucose kind of being infused into the system, like you don't really need that glucagon around. You're going to find that a lot of diabetics have issues where they are not having appropriate suppression of that, and they actually still have way too much glucagon around, and that's driving up their blood sugars as well. So that'll be a problem we'll see some drugs trying to address later on. So, and again, when do we kind of see type 2 diabetes really kind of manifest? And it's not really until you have a pretty significant destruction of those beta cells, because we have a lot of reserve in the pancreas. Over time, you're going to have destruction, and by the time you actually get a diagnosis, you're going to have about 50% normal function. This is kind of the similar feature for a lot of nephrology-related issues where you don't really notice someone's in renal failure until you've lost a lot of those nephrons already, because we're kind of built in with some redundancies. We have a lot of kind of excess materials to work with initially. Once we get rid of about 50% of that, that's when stuff starts to manifest. So, looking at type 1 diabetes, again, most of the time this is an autoimmune condition, as we've alluded to, where the body's attacking those beta cells, and they are going to become insulinopenic by destroying all those cells, and they won't have anything to release, essentially. We won't get much further into it than that. But again, the main treatment for a type 1 diabetic is exogenous insulin, right? So there's not really going to be a role for many other types of therapies. Insulin's really going to be the way to go for them. So insulin itself is going to be usually released as proinsulin, which is going to be a combination of the insulin plus C-peptide, and typically gets released in response to elevated glucose, right? So glucagon's working, increases blood glucose levels. That will cause the negative feedback loop to initiate, and you're going to be releasing more insulin to try to drive glucose levels back down by either getting it converted to glycogen in the liver, getting it shuttled into the cells. Eventually, it may be stored as fat, especially if you have a lot of excess glucose. Now, C-peptide itself is not super not known to really have a function here. However, it can serve as a good index for insulin secretion. So, again, the example I always take it back to is if my wife ever tries to kill me, which could happen any day now, and I were to die of hypoglycemia, you could actually measure C-peptide levels to figure out what type of drug she actually used to kill me with. So, for instance, if I were to give, she were to give me exogenous insulin to try to drive my blood sugar down, would you expect to find a lot of C-peptide? No, because it's all exogenous insulin, right? So again, it does not come compounded with that C-peptide already. However, if she gave me a drug that tries to trick my beta cells into spitting out more insulin, how would your C-peptide levels look? They should be elevated, right? Because they would be elevated along with that natural insulin I've been releasing myself. So we'll find some drugs that can affect that, but sometimes you can use that C-peptide to serve as an index of how much insulin they're secreting. If the C-peptide levels are very low, that gives you a good sign that you're probably not releasing a whole lot of insulin in the first place, right? Because they're going to be coming out as a one-to-one sort of feature there. So I'll show you a picture of that in a second. But basically, you're going to have this insulinase enzyme that will break those bonds and will liberate the actual insulin so it can go and interact with the different tissues there. Now, the liver normally carries a majority of insulin. However, some of the kidney is also responsible for some of this as well. And clinically, this can become relevant. So if you have a decreased kidney function, which, who might have decreased kidney function? Type 2 diabetic, right? So with depressed renal function, they can actually hold on to insulin for longer. So if I were to give a type 2 diabetic had poor kidney function a dose of insulin, that sticks around for longer and could increase my risk for what? Hypoglycemia, because again, that's going to be one of the biggest risks for these drugs. Insulin, again, is another thing that can absolutely kill somebody by causing hypoglycemia, right? Easily correctable, but if you don't know about it, it can be a big problem for these patients. But anyway, typical half-life of the insulin that we release normally is going to be around 3 to 9 minutes. We're going to see that the different formulations of insulin we have can change pretty dramatically based on that. Some of that can last 12, 24 hours. Some of it can last much shorter than this. So we'll look at some examples of that in just a few minutes. So typically, you're going to find that the pancreas, when it gets exposed to increased glucose, you're going to have these Glute transporters on the beta cells. Once that gets activated, it will then get internalized, and then it'll basically be oxidized to ATP. ATP we know is our energy currency, basically, via that TCA cycle. You guys remember we went over the whole TCA cycle? How much fun that was? I'm not going to go over that in detail again. Just know it's happening, okay? That's how we're getting ATP here. Basically, what happens when ATP levels start to increase due to all that glucose we're infusing into the beta cells, you're going to find there's these potassium channels that actually close. Closing the ATP-dependent potassium channels. Based on this, so if I close these outward K channels, the K levels are going to build up. What do you think that does to the electric potential of the cell? K is staying in now, more so than it would normally. Should go up, right? Because again, K is positive, right? So again, it's a cation, should be going up. By doing that, it's actually going to depolarize the cell. Okay, So by depolarizing the cell, you're going to actually open up these calcium channels, and then once calcium channels come in, or the calcium starts to come into the cell, you actually will stimulate release of insulin via these vesicles. And I'll show you that in just a second here. This is going to be important. The reason why I kind of go over this in so much detail is because some of our drugs called sulfonylureas. Have you ever heard of like lipizide or glyburide? This is how these drugs are working. So this is important to know that we can actually stimulate our own body to produce more insulin by using drugs that will affect this these channels here. In this case, sulfonylureas actually will block ATP-dependent potassium channels, and that will help to stimulate that release there. So again, I did not draw this myself, even though it looks like I might have. Actually, it's probably too fancy for what I would have done. But anywho, so imagine glucose comes in, gets transported into the cell, gets converted to ATP. That increased ATP will then close these potassium channels, so now potassium cannot flow out. They'll depolarize the cell, open up calcium channels, they're voltage gated, calcium comes in, and it will stimulate exocytosis of insulin, right? So if I had something like a sulfonylurea come along and actually close off this channel, then that can do the same thing. So I can actually have a drug already working here to increase our own release of the insulin there. So again, that's why, as I mentioned, if my wife was trying to kill me with sulfonylurea, you would see high levels of C-peptide because that gets released along with that insulin, versus if she tried to kill me with the exogenous insulin. I'm trying to give you a hint in case she ever tries to kill me, ever die of mysterious circumstances. These are all clues. This is why I videotape these things and post them online. You guys ever listen to Serial? The podcast? It's kind of like that, okay? I'm trying to leave the documentation here. Anyway, so once we have the insulin being released, it's going to be stimulating glucose uptake into a lot of target tissues. There's several different glute transporters. I'm not going to get super granular on which glute transporter is where. However, just know there's different varieties of them, and these can be important because, again, if you think about a lot of these receptors, like they tend to get downregulated. If you're constantly kind of bombarding the cells with all this glucose, they eventually get downregulated, right? So that's where some of this insulin resistance is starting to pop up here. And so again, I can overcome this with more insulin, but a lot of times you're going to find that's kind of self-limiting. This is why insulin sensitizers are going to be so important here. But basically, once you have the channels being activated, you have translocation of glucose into the cell, and they can be utilized for energy or as storage as glycogen, or eventually turn into things like lipids and all that kind of good stuff. So again, this is more complicated than what we're going to go into for our purposes, but just to kind of show you, here is an insulin receptor. Once it notice this is a tyrosine kinase receptor for anyone who's interested. However, it will bind up with the insulin. This will eventually lead to more translocation of these glucose transporters. Basically, you see these GLUT4 transporters here inside the cell. They'll get translocated out here, open up, and then allow glucose to flow in. Okay. So again, if you had less insulin receptors, it's going to be harder to get those GLUT transporters out there, right? So again, this is why it's important to know that we want to have as many of these out here. We want to be as sensitive to insulin as possible. And this is the main problem with type 2 diabetics. They're very insensitive to this insulin effect. Okay. So again, I'm not going to get super in depth on this. Just know there's lots of varieties of GLUT transporters out there, and that they have different actions. Some of them are for the brain, some of them for the tissues. It just depends on which one you're dealing with. Anywho, so in the end, we're going to see that in the liver, when you have activation here, we're going to be stimulating. When you have insulin interacting with the liver, it's stimulating storage of glycogen. So again, glycogenesis would be the term for that. Conversion of fatty acids and VLDL, and then eventually into adipose tissue. So again, too much carbohydrates around, so it gets stored as fat. And then insulin will actually inhibit glycogenolysis. Will inhibit gluconeogenesis, right? So we want to try to be in a storage sort of standpoint. Insulin will inhibit that, and will potentially inhibit conversion of fatty acids to ketones. That's important because when we talk about diabetic ketoacidosis, they're actually producing way too many ketones. That's because they have a lack of insulin. Okay, kind of goes back to that. In the skeletal muscle, you're going to be stimulating storage again of carbohydrates as glycogen, storage of amino acids. This is why insulin is a anabolic steroid in a lot of cases, or you can kind of consider an anabolic steroid. Is anyone like kind of big into like bodybuilding culture? That would look at anyone in particular like, into bodybuilding. Anyway, you can see that some of those guys will actually utilize insulin. They actually use it as an anabolic steroid because it will help. They'll use it post-workout in conjunction with glucose and amino acids to try to stimulate uptake into the skeletal muscle tissue to stimulate growth. Okay, so it is definitely a growth factor there. So again, it's going to be good for the muscles. It'll actually inhibit protein degradation to amino acids. Right, we want to try to store those up as much as we can if we have a decent amount of insulin. Versus on the adipose tissue side, you'll see storage of fatty acids as triglycerides eventually kind of stimulates fat storage. And then if it's going to be inhibiting liberation of those triglycerides to fatty acids. Okay. So looking at insulin release, do we always release a certain amount of insulin all the way throughout the day? Right. So it's going to be very much based on things like glucose intake, based on glycogen or glucagon levels. It's going to be going along, and if you kind of look at it, you'll see it kind of goes along with meal times, right? That kind of makes sense because when we have increased glucose coming in through our diet, what does our pancreas want to do? Store it. It wants to get rid of it into the muscles, into the liver, so it's going to stimulate insulin release. So looking at release of insulin, you're going to see there's a certain basal amount of insulin that may be released throughout the day, but you're going to see really that the big spikes from it come during breakfast time, right? May see a little biphasic peak here at lunchtime, see some insulin going up, and then around supper time, okay? Again, you're always going to have a basal amount of insulin being released, but you're going to have these big spikes when you have increased glucose uptake. Looking at your basal glucose, you're going to see that, yes, you should have a basal amount around. If this was 0, you'd be kind of dead, right? Because your brain needs that glucose. But you should see the levels will spike up around mealtime, should go back down, spike up around lunch, spike around supper time, right? So again, this kind of makes sense. We already kind of are familiar with this process. And again, if you were to see this, you'd see kind of inverse effects on glucagon. Normally around mealtime, glucagon should be depressed, and again, around all those meals there, okay? So looking at the actual insulin formulations themselves, we have about 17 different formulations are available. There's a lot of them that are out there. So our point here is to kind of show you the different types that are available. There are different roles in treating a diabetic patient. Because again, if you think about it, when we're dealing with a type 1 diabetic, we have to replace basically the whole pancreas for them from an insulin standpoint. So we need to give them all of that insulin they would normally get throughout the day. Versus like a type 2 diabetic, you may be able to get away with using kind of a partial replacement, only giving some of that insulin that we would be releasing otherwise. We'll look at some examples of that. Basically, they're going to differ in their onset of activity, so how quickly they're going to work, their duration of action, so how long they're going to work for, and their solubility characteristics. So this kind of helps with delayed release of some of the medications in some cases. And their profile can be varied by lots of things. So by changing things like zinc concentrations, that can affect that. By adding something called protamine, you can have certain types of insulin. And actually, we will change the amino acid sequence of insulin in a couple of cases to get different varieties of insulin. Right, so we can actually change a few of these things to change the amino acids, and they have different characteristics as far as their onset and the duration of action, etc. So here is insulin. This is actually proinsulin right here. So notice the C-peptide right here. This is actually what gets cleaved off by insulinase, and this is the active form here. Notice the two disulfide bridges that hold the two arms of the protein together, and that's the active insulin. Okay. Now, you don't need to memorize this at all, but you do need to kind of be aware of some of the different things we can do here as far as like changing amino acid sequence. Just kind of be familiar with the fact that that is one thing we can do to change the characteristics of insulin. So for instance, we have one called Insulin Lispro. So that kind of goes into, tells you directly what it's doing right there. So notice here it's converting this proline and lysine to a lysine and proline. So just by switching the amino acids, you get a different profile. You can have it act very differently as far as how quickly it works, how long it's going to work for. So these are little things we can do. Sometimes we can add on a few proteins here, or we can change a few things. And basically, get all kinds of different types of insulin here, right? Notice here that we used to use porcine and bovine insulin. So for a while, we didn't have the ability to produce insulin ourselves. We didn't have like a recombinant form. So we did have to use animal products, okay? Does anyone know any kind of risk with using animal products? Yeah, because the allergy to it, right? So you can actually have some issues where you can have an allergy to it. Also, there's like, certain religious concerns for some people. They do not want pork products being infused into them. And so there's some issues with that. That goes for like things like if you have like a porcine valve placed in your heart as well, maybe some religious concerns with that for some individuals. But this is what we used to use. Nowadays, we don't have to. Now we have recombinant insulin forms that we can actually manufacture ourselves and administer. So again, beef is actually no longer available, very antigenic, and then pork may only be available by very specific circumstances. I believe on your third order, you actually get a free side of bacon with that, so it's kind of nice. But nowadays, we have human insulin that is recombinant that we actually form in E. coli or in yeast in some cases. So depending on the source of it, you actually get the different, these are the different manufacturers, and then get the different brand names. So for instance, from E. coli sources, we get Humulin, which are going to be Lilly products, not my daughter Lilly products, but the company Lilly products. Isn't that kind of funny? The two pharmacists named their kid Lilly. I didn't even think about that until after she was born, but I don't know. Anyway, and then Baker's yeast is where you get Novolin, which is a Novo Nordisk product, right? It would have been weird if I named my kid Novo Nordisk, though. It's worked out. Anywho, but if you hear like Novolin, you hear Humulin, this is where these different products are coming from. Is their different manufacturing process of how they actually produce the insulin themselves. So here are the ones you need to be familiar with. We're going to start to go through. So here is we have a few that are ultra short acting. So they're going to be very quick onset, very short duration of actions. We're going to see our insulin Lispro, insulin Aspart, and insulin Glulisine. We'll talk about these more in detail in a few minutes here. There's a short-acting or regular insulin. So the regular insulin should look just like the human form that we produce ourselves. So this is strictly analogous to what we produce. Okay. There's going to be intermediate acting, which is going to be our Mph insulin. We're going to have long-acting forms, it's called ultralente, which is actually, these two we don't really use that too often anymore. But what we do use quite frequently are going to be ultra-long-acting insulins. So this is where insulin glargine, Detamir, and Degludec come from. Degludec is the newest one. And then there actually is an inhaled form called Afrezza. So anyone think they can inhale insulin? Yeah, so there's actually another product that's out. This is back when I was in pharmacy school. It came out, it actually bombed, didn't do very well. But now we have a newer one called Afrezza that some patients might do okay with. I'm going to mainly focus on the ones that we're going to be giving. Actually, what route do you give insulin normally? Yeah, usually subcutaneously, right? Because again, these are proteins that would just be degraded by the GI tract if you administer them orally. So you cannot do oral insulin, at least at this point. However, you can do sub-Q. We can do IV for some of these, just depends on the patient, but sometimes you'll see that inhaled form being used. But again, I have no experience with it, so I'm not really going to talk to it too much, just know that it's available out there. So anyway, looking at the different characteristics here, you can see kind of what the different effects are going to be. So again, looking at the time frame for the drugs, and then looking at, basically this is a glucose infusion rate. This is how much glucose you'd have to give in order to keep the blood glucose levels the same for the patient, right? Because again, insulin is going to be driving glucose into the cells. We have to give glucose in order to make sure we keep things balanced, because otherwise what would happen to the patient's blood sugar? Drop, become hypoglycemic. So basically, your very short-acting ones, you're going to have things like insulin Lispro, Aspart, Glulisine. I'll show you the brand names here in just a few minutes. But you're going to get very rapid action, but it's going to go down pretty quick. By 4 or 5 hours, it should be out of the system essentially, right? So again, what time frame around what times do you think you'd want to give this insulin? Around mealtime, yeah. So you want to give this around mealtime because that's when you're expected to get a big bolus of glucose. You want to give this around mealtime, drop their sugars back down. Okay, makes sense. Regular insulin similarly would be given around meal times, things like that. And then when you're short or your longer acting formulations, these are going to be better for kind of basal insulin effect, right? So for a type 1 diabetic patient who produces no insulin of their own, they would take this every 24 hours or so, this long acting form, and that would kind of replace the basal insulin that the patient would have been normally releasing themselves. And sometimes for type 2 diabetic patients, you may give this so that way they're not having to take mealtime insulin. They just have to take, say, 1 dose throughout the day. Okay. And again, a big problem here is going to be compliance, because who likes to inject themselves? Actually, don't answer that. It might be incriminating. But no one likes to give themselves sub-Q injections if you don't have to, right? So this is the thing where you can maybe injecting yourself 4, 5, 6 times a day, depending on the regimen. And so if we can avoid that, it's always going to be best. And so we'll look at some cases where we can actually combine therapies and try to limit how often they're having to inject themselves. So anyway, anyone ever seen an insulin pump before? Yeah, so insulin pumps are really cool devices. It's kind of neat because whenever we have patients who come in on an insulin pump, especially pediatric patients, a lot of these adolescents, they know so much. Like their minds are little sponges, and they know so much about their disease. They know so much about how to manage their sugars that they know way more about this stuff than I do even, right? So when they come in on an insulin pump, our goal is to go in, we actually make sure that it's the pump's actually working, make sure that the drug's in there, it's not expired, anything like that. And you have to make sure the patient knows how to actually operate it. So we actually go through and ask them, okay, well, how would you do this? How would you do this? And they're able to rattle it off. They're sitting playing video games, and they're like, yeah, I just do this, and here's my insulin correction factor, and here's my blah, 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 here's my basal rate, my bolus rate, and all this kind of stuff. And they know everything about it. It's amazing. But here's kind of where we started with insulin pumps. Not the most, fashion-forward sort of device there. Kind of looks like a proton pack from the Ghostbusters maybe, but that's what we had for a while, right? So not a great solution in that case. But nowadays they're super small. You can inject the drug directly into this compartment here, and then you'll have a little sub-Q catheter placed that will stay in place for a period of time. I don't know how often you actually change it, but that will stay in there for some period of time. And that way we're kind of replacing their pancreas essentially. That's acting as an automated pancreas for them, where it will supply a basal amount of insulin throughout the day, and then when they need a bolus in response to food, they can go ahead and just program that in, and boom, they're set. Right? Now, the ultimate goal would have something that can actually do it automatically based on measuring blood sugar levels, but we're not quite there yet. But that's certainly something that may happen in the future. Here's an example of what that Afrezza looks like. So this is actually a device where you'd have the inhaler here. You place the cartridge of drug into it and then apply a mouthpiece. And so that's how you have the inhaled insulin. So just kind of show you a picture of what that looks like there. But again, these are continuous subcutaneous infusion pumps. This is another thing we'll run into where if you, do you think these devices are 100% foolproof? No. So the problem is we run into is you may have malfunction of the devices, which can lead to hypoglycemia if it's given too much, or hyperglycemia more often than not if it doesn't give enough. Or if you have an issue where a patient becomes sick, become ill. A lot of times illnesses are a reason why patients are coming into the hospital because again, once you become sick, like it usually will throw your blood sugars off really kind of through the roof there, or it kind of just it becomes much more unpredictable. And so sometimes they have to come in to get managed for that. Anywho, here are the different varieties that are available. You don't have to know necessarily the different options and how they're coming, but just be aware of the different options that are available to us kind of globally. So some of them will come in vials where they'll have a certain amount of insulin in there. You can draw out the doses to administer them. Some of them actually come in pens. So you ever seen these like pen devices? Basically, there'll be a number. You'll be able to dial in how much insulin you want to administer. There's a pen needle that you'll attach to the end of it, and you'll just apply that subcutaneously, and then just press the plunger and it basically would inject it. Now, who do you think that might be an issue for? Yeah, it might be tough for kids who, usually their parents are helping them to manage that if they need help with that. We mentioned older patients, right? So if you have arthritis, right, that can be very difficult to do that. How about with the dose, actually dialing the dose? If you have vision problems, they might not be able to see what number they're actually dialing in. They dial in too much, and all of a sudden they're hypoglycemic, right? So there's some concerns with this. You have to be careful with all of these because, again, these are very deadly medications in the wrong hands. However, they're very safe and effective if used appropriately. So be very, very careful with these. And in fact, having insulin errors where, one is mixed up with a different dose or like a different variety can lead to some pretty significant problems. So this is why, like in hospitals, we have double checks every time we give insulin or we administer an insulin dose by the nurses. By the pharmacist when we're drawing it up. We'll actually have one pharmacist draw it up, and then we'll have another pharmacist check to make sure it's actually the right type of insulin, because if you inject the wrong kind, it can be potentially catastrophic. However, here are some of the different varieties. You have Humalog and Novolog. When you see log, think fast acting. These are going to be your very quick acting, rapid acting insulins. And we also have Apidra, which is that insulin glulisine. These are your three really rapid acting. You can give these either right before, or actually the Apidra is so quick acting, you actually give it at mealtime. You usually want to give it a little bit beforehand to give it time to get absorbed. You have your short-acting insulins, which are regular insulins. So see Humulin R, Novolin R, it's just the different companies, right? We already talked about that. And when you see U100, what do you think that means? How is insulin measured in dose? Units, right? So you need to write out units. Do not write out U. You will be heavily discounted on your grade if you were to put that on anything I'm grading, right? Because it can be mistaken, right? So if you write 10U, what could that potentially look like? 100, right? And actually I saw some examples too recently on your guys' stuff where I saw some things that actually if you could very easily be misread as like for instance, like you're like missing like a trailing zero or a leading zero in the wrong place, like you could really screw up the dose, right? Same thing here. So you got to write out units. Don't have to write out international units. It's too much. Just write out units is fine. But U100 stands for 100 units per ml. There's also, especially for some of these diabetic patients who are very, very insulin resistant, they need such high doses, they have to have a higher concentration. There's what we call U500. So imagine if you screwed it up and gave U500 instead of U100. Again, you could potentially kill somebody, right? So you got to be very careful with insulin. But those are the regular varieties. And then you have your intermediate kind, which are called Mph insulins. These will have Humulin in, Novolin in, and then the long-acting form. These are the ones you'll use probably most often for kind of long-acting basal insulin. This is going to be your Lantus, which is insulin glargine, Levemir, insulin Dedamir, and the Tresiba, which is that Degludec. Those are the most common long-acting form insulins you'll have there. There's also some mixes you'll find there. So sometimes they'll mix different varieties of insulin. They'll mix a short-acting form with a more intermediate-acting form. This is to help deal with trying to limit the number of injections you're having to give these patients. So let me see these used occasionally. Here's some Mph combinations. And then I mentioned the more concentrated forms of insulin that are out there as well. You got to be very careful anytime you're mixing up your concentrations. And I mentioned the inhaled insulin, the Afrezza. This is one of my favorite drug names because it comes as a technosphere. Like, who thought of that? That was a pretty good name. Sounds like I don't know, something from like Mad Max maybe. 2 people enter, 1 person leaves the technosphere. No, okay. Needed some crickets, but anyway. So this is a good table. again, you don't have to memorize the specific numbers, but just kind of get a feel for how these different insulins are going to be working. So, for instance, your rapid-acting insulins, Aspar, Lispro, Glulisine, you can see their onset within 15 to 30 minutes, right? So these are very good for mealtime sort of insulins. However, the duration, not very long, right? So these are not good for long-term control of their blood sugar. However, if you're looking at your long-acting forms like Detamir, Glargine, Degludec, they don't kick in very quickly. Maybe 2 hours, 2 to 3 hours. However, they're working up 24, 36 hours in some cases. So these are very good for kind of basal control. And so this will be important to kind of keep those distinctions in mind when like test questions come up and say, okay, well, which one of these insulins will be good around mealtime? Which one of these insulins are good for basal control of glucose? And be able to identify, is this a long-acting or short-acting form, or intermediate in some cases, right? Okay, so as far as complicated, I'll finish when I'm done with the insulin section. I won't go through all the endocrine, all the diabetic drugs, but I'll finish the insulin stuff. So obviously the big complication, what's the number one side effect? Hypoglycemia. This is what can potentially kill somebody, especially if they're not around like someone else. If they become hypoglycemic by themselves, this can be pretty terrible, right? So I know one person who had her husband was a type 1 diabetic, and she actually went off for a business trip and came home, and her husband had a hypoglycemic incident. Doesn't know if it was due to insulin or due to illness or something like that, but basically came home and he'd been dead for 2 days, right? Very sad cases like that. So you want to be very careful with insulin due to this hypoglycemia. And again, look at the concentrations. You 100, 200, 500. You screw that up, you're in big trouble, right? Medical legally speaking, you're in big trouble if you screw this up and hurt somebody, right? Now, there are some cases where you can have an allergy to insulin, right? So you can actually have an anaphylactic allergy to this. Very unlikely nowadays. However, this is somewhat of a risk, but you saw this more like bovine products and porcine products. We don't do that too much, or see that too much anymore. However, you can get this immune insulin resistance. So this is actually a form where you're generating antibodies against the insulin proteins, where you're not getting anaphylactic, but they're inactivating the insulin. So you may see some actual insulin resistance to the exogenous forms that we're giving there. So you gotta be careful with that. You may see some injection reactions. Usually like to warm up the insulin a little bit because the cold insulin can cause some vasodilation. May look like a injection site reaction there. You should rotate the site and where you're injecting, not to the same site every time, because you can see we call it lipodystrophy that can happen there. You want to avoid that. And then obviously, like I said, insulin's an anabolic hormone, so your weight typically tends to go up. Right, and so I've seen some patients who come into they come in for DKA because they're trying to lose weight and they wanted to try to limit how much insulin they were taking as type 1 diabetic patients, and they they can get themselves into trouble if they're not careful with that. So again, let them know weight gain is as a side effect. That's just how the insulin normally works, right? Okay, what's some left with an insulin section? I'll just talk about this real quick. So just know that drugs that can decrease the hypoglycemic effects of insulin are typically drugs that are going to be increasing blood sugar typically, right? So again, they're going to have kind of an antagonistic relationship here. But things like thyroid hormone, smoking, epinephrine, they tend to increase blood sugar levels. And so this is going to be kind of fighting that a little bit. So you may see the insulin working less effectively when they're having concomitant administration with some of these substances. So just kind of keep that aware. And anytime you're dealing with other drugs that can lower blood sugar, that can also lead your the insulin to work too well. You can see hypoglycemia. So potentially things like alpha blockers, beta blockers, alcohol, all lead you to predispose to hypoglycemia. So be very careful when mixing these drugs with insulin, because again, you can have kind of unpredictable effects on their blood sugar. So typically all your new diagnosis type 1 diabetics, they're going to get insulin because again, they're insulinopenic. They cannot produce their own insulin. Insulin resistance is not their problem. Mainly they're not having enough insulin. Sometimes pregnant patients with type 2 diabetes or women who develop gestational will get insulin. We said that was a drug of choice for many of those patients. And then if they're type 2 diabetic where diet, exercise, and oral medications themselves are not working, that would be another indication. We would supplement them with some exogenous insulin. Certainly DKA, I'm not going to cover specifically here, but just know that as due to the body kind of switching over to producing ketones, does not have enough sugar in the actual cells, so they produce the ketones instead. So insulin is the correction for that. And then also similarly, this is more seen in type 2 diabetic patients, but it's hyperglycemic hyperosmolar non-ketotic syndrome, or HHNS. These are patients who are coming in, their blood sugars are like 500, 600, 700, very, very high blood sugars. They're also managed with insulin as well with that. And then anyone know why we use it for hyperkalemia? So this goes into something you'll see that when you have insulin interacting with the cells and you're causing glucose to come in, that's not the only thing it affects. It also affects amino acid intake. It also affects potassium intake. So what we'll actually do if we have a hyperkalemic patient in the ER, we'll give them a dose of glucose and insulin in order to drive that potassium into the cells, and that will actually cause a potential temporary shift and help get their K down into a little bit safer level. Okay, so that's one thing you might see. We'll probably talk about that in the ER section a little bit later on. Okay, so I'm going to cut it off here. We'll talk about insulin regimens a little bit later, just kind of more in depth than I want to get into right now. Any questions I can answer for you currently? All right, thanks so much. I know it's a long time, but giving you guys a little bit of a break. See you next time, next week, whenever. All right, any questions from our 4-ish hours the other day? Everyone recovered well? You know, going through that kind of hardship probably made your weekend that much sweeter, right? The worse the hardship, the sweeter the weekend. That's what I always say. Anyway, so we're going to continue on. We were talking about insulin. We were talking about diabetes. And hopefully we'll finish out this section today. If not, it'll bleed over into our review session on Thursday, and then we'll do the Kahoot review, and then your test is Monday, right? All right, fantastic. Seems so quick. Probably it's like someone took a month off or something to have a baby. It's weird. Anywho, so the big thing here with insulin is that you have to make sure that the carbohydrate intake is going to match how much insulin you're giving, because otherwise, if that does not match, then what happens? If I do not have enough carbohydrates for the amount of insulin I'm giving, I get hypoglycemic, right? On the flip side of that, if I have too many carbohydrates, not enough insulin, they get exactly, very intuitive stuff here, right? So the other things you have to take into account are things like physical activity, like that can increase the amount of glucose the person's using up. Perhaps you don't need as much insulin, right? That may predispose to having hypoglycemia. But the goal is to try to mimic our insulin administration as best we can to mimic kind of the pancreas, right? So we can do that pretty effectively with things like you know, an insulin pump, right? Because that can have a basal rate of insulin being released throughout the day, along with having kind of the ability to do boluses, you know, for instance, around meal times, things like that. But, you know, when you're having to give yourself injections, you're not going to be able to get that kind of consistent or get that as close of a kind of a mimicking kind of effect here. Because, again, you don't have to inject yourself, you know, a dozen times a day. So we try to limit that. Try to only have them inject themselves maybe like 3 or 4 times a day if possible. But certainly there may be some difference in regimens there. Now, the thing we're going to look at is we talked about the different types of insulin that are available. So we have very short-acting insulin. You guys remember any examples of that? The short-acting insulin? There's like Humalog, Novolog, those are good ones. There's that insulin glulicine or Pid Dose, it's very fast acting. So those are quick acting. Those are good around what times? Yeah, usually around meal times, right? Because you want something quick acting because you're having a lot of glucose coming into the system at once. Versus, you know, your longer acting insulins, which are going to be better for, say, like in the morning sort of administrations. That way it'll kind of carry you throughout the day to kind of mimic that kind of basal amount of insulin that your pancreas releases normally. So again, you're going to find that if you were to just do like twice daily administration, you can't really adequately mimic what the pancreas is normally doing because you don't really take into account those kind of mealtime boluses there. So, and again, if you're looking at a type 2 diabetic versus a type 1 diabetic, who do you think gets more insulin shots? Probably type 1, right? Because we're supplying all of their insulin exogenously versus a type 2 diabetic. They probably still have some residual insulin function. We're just trying to overcome that glucose or that glucose intolerance that the patients have. So you can kind of keep that in mind. You may see a type 2 diabetic only being on say 1 shot a day versus a type 1 diabetic would be on multiples kind of at a baseline. And again, looking at if we were just to do like twice daily dosing of insulin, you really wouldn't be able to cover these kind of big peaks here, right? You'd only be able to get kind of a basal amount going along with that. So that's why we kind of have these more intensive sort of regimens. So as I mentioned, that generally insulin doses should change depending on the amount of carb intake that they're going to have and the amount of exercise that they're performing. So more exercise probably means less insulin is going to be needed because they're going to be utilizing a lot of that glucose on their own in those cases. If their carb intake is going to be low, they probably need less insulin, right? So if they're going to skip a meal or something like that, they probably should skip that dose of insulin as well. So these are things to consider. And a lot of times, you guys ever heard of, we'll talk about some of the different regimens, but a lot of times what you'll see in these orders, and I see this a lot for our diabetic patients who are getting admitted to the hospital, is that they will have, say for how many ever, in the instructions of the nurses, it says, for how many ever carbohydrates they're taking in a meal, this is, their insulin sensitivity factor. And then this is how many, you basically do a little calculation and you figure out how many units of insulin you're going to give. Because remember, insulin is based in units, right? Not milligrams. That's different. So I was going to get into that. So sliding scale, anyone know what a sliding scale is? Yeah, so that's going to be strictly based on and what I was mentioning there just a second where or when I mentioned when I said based on the amount of carbohydrates that you're intaking and you figure out your insulin dose. That's kind of more of a proactive feature. That's more of a carb counting sort of method versus the sliding scale is much more reactive. So for instance, I check the patient's blood sugar, it comes back, say 200, I'm going to give this many units of insulin versus if it comes back 300, I'm going to give this many units of insulin. So the scale slides based on what their actual blood sugar is and based on how many units you're going to give. When you're doing the carb counting, you're factoring in things like the insulin sensitivity factor, which is going to be different based on every patient, depending on kind of what their baseline ability to react to insulin is, and that will kind of be and you'll find that endocrinologists will kind of play with that and try to figure out kind of what's best for each individual patient. So. And again, this could be problematic because imagine, you're admitting a patient to the hospital and you need to get all their orders set up, right? So you're trying to get all their insulin orders done appropriately. And, the question is, well, how do I know how to dose their insulin, right? So especially if you're having to do these kind of comprehensive carb counting regimens you're putting in there, it's nice over at Nemours. Everything's kind of in-house in a lot of cases. A lot of our patients who get admitted are also seen by endocrinologists of Nemours. We can just basically do copy and paste out of the endo's notes, put them into the orders, into the admin instructions, and then boom, you're set, right? The nurse has all the information right there, but you could imagine the risk for having things like transcription errors where you could have, the wrong information being copied down and then boom, the patient's getting the wrong type of insulin, the wrong dose of insulin. So again, insulin can be pretty deadly if you screw it up, or, you run the risk of being hyperglycemic on the flip side of that if you don't get enough. So you gotta be really careful with this stuff. A lot of medication errors involved with insulin. Want to be really careful. So anyway, so I mentioned that typically the long-acting insulin forms are going to be taken either in the morning or they may be in the morning and the evening. A lot of times we're trying to shoot for ones we can just give one time a day. Depending on the patient, they may need it more often than that. And then the regular to ultra rapid acting are usually taken around mealtime. So I mentioned the sliding scales, typically based on these kind of preprandial glucose readings, and then you can actually kind of factor in. At that point, basically correction factors. So you'll find out for each individual patient kind of how much 1 unit of insulin should change your blood sugar. Again, that'll vary based on patient to patient and can vary over time as well. They can develop more or less insulin resistance as time goes on. And then I mentioned carbohydrate counting, where you're adjusting insulin based on the anticipated carbohydrate intake, right? So basically you're looking at, they're going to be taking in 20 grams of carbohydrates. This is how many units of insulin I'm going to need to counteract that, essentially, keep kind of a normal resting glucose. So you can imagine here we're going to see glucose levels on this top line here. You're going to have patients kind of a normal plasma insulin concentrations that would be released in a patient without diabetes. And then you're going to see these different insulin regimens that we can administer to some of these patients. So in this top one, again, normally you see these spikes around what times? Meal times, and you're going to have basal glucose, right? Your basal glucose should not be 0, otherwise you'd be probably dead, right? Probably would not be too compatible with life, as they say. And then looking at normal plasma insulin concentrations, again, normally see the spikes around mealtime. You're going to see there should be some basal amount of insulin being released here. So that's what normal insulin secretion looks like. We've already kind of seen that. Now, and again, the purple bars here are going to be the mealtime. So imagine you're going to give a patient insulin with regular insulin around meal times, and then you're going to use one of those intermediate acting Mph insulins. It's not Neil Patrick Harris insulins. He doesn't get any cut of that when you buy that stuff. But no Mph fans? Anyway, so this is more of an intermediate acting sort of insulin. So this is one you would give, say, twice a day. So the kind of the dotted line here would be the Mph insulin. So you notice here how it has a pretty slow onset. You give it in the morning time and it really doesn't peak up until around lunch. And then you give a second dose in the evening. So that way you get kind of better 24-hour coverage for that basal amount of insulin the patient will be experiencing. And then you get regular around breakfast time and then around dinner time. Again, notice how regular insulin is not super fast acting. As compared to like Humalog and the Novolog we saw before, but we'll have a little bit in between the intermediate to the short acting. And so you see here, notice here you're not going to get kind of perfect coverage because there's going to be some delays here in getting kind of peak insulin levels. So there may be periods of time where they're hyperglycemic and take some time for the insulin to actually kick in. Versus if you were to give someone, say, regular with an ultra lente form of insulin. We don't use ultra lente too much anymore, but you can kind of substitute this with something like insulin glargine or Dedamir. So Dedamir's Levemir is the brand name for that, and insulin glargine is Lantus. And so if you've heard of those brand names before, you be somewhat familiar with that, but basically sub that in where basically they're getting 1 dose a day, and it kind of provides nice 24-hour coverage, and then you can supplement with kind of regular acting insulin or fast acting insulin around those meal times, right? So again, we're trying to mimic what the pain curves would normally do, but also trying to minimize how many injections we're having to give these patients. And here would be if you had a person getting regular insulin via an insulin pump. Notice here how it would have a basal amount being released throughout the day, and then the patient can program in the boluses around those meal times. So if they know how many carbohydrates they're going to be intaking, they know their insulin sensitivity factors, they can say, okay, I'm going to have this many units and have a bolus programmed in, and they can do it right from the pump itself. And again, those pumps are very small, very tiny, very convenient for the patient, kind of attach it onto their belt, and honestly, you wouldn't really know it unless you knew what you were looking for. Any questions on that? Okay, pretty straightforward. So looking at, I'm not going to ask you specific insulin dosing on this by any means, but just to kind of give you an idea how we would dose this for these patients. So typical, looking at dosing here, so type 1 diabetic between 0.5 to 0.6 units per kilogram per day. So you could use this as kind of a baseline saying, okay, well, we'll start with this, and then we can adjust it based on how the patient's responding to it, based on those kind of individual insulin sensitivity factors. Type 2 diabetic, why do you think that dose is so much higher? They have a lot of insulin resistance, they have a lot of glucose intolerance because of the fact they've been kind of chronically kind of assaulting all those cells with so much insulin, so much sugar for such a period of time, they become very resistant to it. So they need a lot bigger doses in order to counteract that, right? So we're kind of trying to fix the problem with numbers, with just more insulin rather than trying to fix the underlying problem. So this is why when we talk more specifically about type 2 diabetic medications, that insulin sensitizing drugs are going to be a key component of that. And you'll actually find that when you use a sensitizer along with the insulin, you can usually drop your doses of insulin down because it's going to be working more efficiently. So we'll look at some examples of that a little bit later. Typically, you break the dose in half, so you'd have 50% say a basal, a long-acting form to kind of get that normal 24-hour sort of coverage, and then you have 50% of it, usually a regular, more likely a rapid-acting insulin that you would give around those meal times. Okay, so that's usually how we end up going about it. Say, for instance, if we had a 40-kilogram female who got diagnosed with type 1 diabetes, you can see here that her normal, say, starting dose would be 20 units of insulin a day. She can get 10 units of that, basically as her. I'm sorry. Okay, so yeah, so this one they'd be doing a BID dosing, so you get 5 units of insulin Dedamir subcutaneously twice a day, because again, we can't give these orally, right? They're proteins, so you have to give subcutaneously. And then the other 50% would be separated around mealtime. So say, for instance, they would get around 20% at breakfast. You know, breakfast is the most important meal of the day. You probably see a lot of carbohydrates there. And then you have 15% at lunch and 15% at dinner. Pretty straightforward. And again, they're all going to be kind of snowflakes, not in the negative kind of derogatory term, but snowflakes in the sense that they're all going to be a little different. They may all need a little bit of adjustment to try to figure out kind of where their insulin needs are going to be, if they need a little bit more in the morning, if they need a little less at night, things like that. And you can adjust that. That's where you're going to have pretty frequent follow-ups of these patients. And they're also going to be taking a lot of measurements. A lot of glucometers actually will have the ability to store a lot of those findings. So that way they, you take them into the clinic, they can look at all the readouts and say, okay, well, I see normally in the morning you're getting hypoglycemic, and try to figure out and try to troubleshoot where the issues are with that. So as I mentioned, insulin pumps. Who do you think is a good candidate for an insulin pump? An older patient? So a younger patient maybe? So what do you think are the kind of the components? Like, what do you think makes a person a good candidate for an insulin pump? They need intact mentation, absolutely. So it needs to be someone who can actually figure out, like, okay, what is this thing doing? What am I doing with it to manage that? So they need to be super responsible, right? They need to actually have a very good understanding of like why they need this, why they're doing it. They need to become very compliant with it, because again, you can screw that up pretty big time. If say, for instance, a person is giving themselves, a subcutaneous insulin 24 hours a day, they skip a meal or something, and they don't kind of set their settings to deal with that, they can become hypoglycemic. Find them down, have to go to the ER, have to get them in, it's no good, right? So typically you need someone who's got pretty good mentation, someone who's going to be able to understand this. So do you think like a 2-year-old would be a good option for subcutaneous insulin pump? Probably not a 2-year-old. It's probably going to be someone that needs to have their insulin administered to them. However, if you had like, say like a young adolescent, even someone who's like 11, 12-year-old, they're very savvy with this stuff and they can become very responsible. Do you think it's good for like a new diagnosis sort of patient? No, because you don't know how they're going to respond to insulin. So these are typically going to be pretty well-established patients, those who have shown good compliance, and they have things like their A1c is in check, which shows their average glucose over that 3-month period is usually in check. They're going to have good readings on their glucometers to show that, hey, they're not really kind of wildly vacillating between hyper and hypoglycemia. You can see patients who can be pretty, we call brittle, or they can be very sensitive and have kind of big swings in that. We don't want those kind of patients. We want someone who's going to be very responsible, someone who's going to be pretty consistent with this. That's things to keep in mind. They need a lot of extensive training, but usually once they kind of get it under their belt and they're set, this works out very well for them because it's very non-intrusive. They just have to have the cannula changed out once in a while. Make sure they're refilling the pump when it runs out. Usually has a space for a few mLs of insulin to be put in there. What type of insulin do you think is going to be best for that? Like a short-acting, a long-acting? You don't want a long-acting. The reason why you don't want a long-acting is because, again, we saw the long-actings, like when do they normally have a peak effect? Like 10, 12 hours from now. It's very hard to adjust that. You want things that are short-acting so you can titrate it very quickly, right? So again, if I'm hyperglycemic, I can adjust the dose up. If I'm hypoglycemic, I can adjust the dose down in order to try to get things back in check. You want short-acting forms of insulin for this. Something like a 24-hour acting drug, it's not going to be good because you can't really respond to that super quickly. So keep that in mind. Okay. And again, have you guys ever seen any of these like kind of like Bluetooth connected like continuous glucose monitoring systems? I had one student last year at a different institution where they actually had a device that was installed that would basically read their blood glucose, and it was hooked up via Bluetooth to their Apple Watch, and they could monitor their glucose in real time. It was actually pretty cool. Some of that stuff has some delays to it. You may find that depending on where you're measuring the glucose from, there can be some time to re-equilibrate. So for instance, if I were to get like an IV stick, that's pretty good estimate of where my actual blood glucose is. However, if I'm doing it from like a subcutaneous site, sometimes that blood takes some time to circulate, and it takes time for that glucose to kind of re-equilibrate. So it's not perfect, but again, we're getting better and better technologies here. To eventually, we are going to have an artificial pancreas that the patient will never have to actually mess with. They can just automatically read glucose and it will respond accordingly. So again, that'll be kind of the near future. Hopefully, we'll get there sooner than later. Anyhow. All right, so looking at hypoglycemia. So how do we treat hypoglycemia? Give them the sugar, right? So you got to give them sugar in order to fix the problem here. How should you give them the sugar? So oral glucose is one option. What they're unconscious. Yeah, IM, IV. Yeah, so we're going to see we have a couple different options. It's going to depend on kind of what your patient state is at the time. So again, you're going to find there can be some issues here where these patients may have this hypoglycemic unawareness, and this can happen due to some of the kind of the microvascular complications here of diabetes, right? These kind of neuropathies that develop over time. How should a person look if they are hypoglycemic? Pale, diaphoretic, tachycardic, some tremor. Remember any drugs that can cover that up? Yeah, remember beta blockers can actually mask a lot of the signs and symptoms. Think of your type 2 diabetics of hypertension. Maybe they'll be on that, right? Right. So again, usually you're pretty irritable, kind of hangry, I would say. So it's important, again, educate on what the signs and symptoms are so they can recognize that and respond accordingly. Again, we're going to be defining this as, blood glucose less than 65 to 70 or so. And again, patients tend to overcorrect when they do this. So again, when you feel hypoglycemic, you tend to want to correct that pretty quickly. So they end up kind of overeating or they kind of overcorrect and they get very hyperglycemic. We want to kind of avoid that. And so what we'll do is called the rule of 15. This goes usually recommended for most patients, where basically they'll try to intake 15 grams of simple carbohydrates. When I say simple, what does that mean? Yeah, it does not take a lot of energy in order to break it down into its kind of component carbohydrates. Something like complex carbohydrates, you think like wheat bread and things like that. Typically take a lot more time to break down. We want simple carbohydrates, so things like orange juice. 8 ounces of orange juice is good. 8 ounces of milk will have 15 grams of carbohydrates approximately. Also, like 4 glucose tablets, they may have that available, or may have that recommended to carry that around with them. A little glucose tablets, and you take 4 of those and check those. Check it again in 15 minutes. And rule 15, and kind of see where they're at. If it's less than 70, then you would repeat that, right? You don't want to have them go and just down an entire loaf of bread or something and try to fix it. Like, you want to try to do it in kind of small increments here. So rule 15 is good to remember from that standpoint. Now, if a patient is unconscious, there's a couple options we have here. So we mentioned dextrose. We can certainly give this. IV, IM is another option as well. Things to remember is that there's several different concentrations that are available. So again, which one do you think here is the most concentrated? Yeah, D50, which would mean basically, when I say 50, D50, what do you think that means? So it goes back to the concentration, right? So remember we talked about converting like a percentage concentration into like a milligrams per ml. So remember I said like 1% lidocaine equated into how many milligrams per ml? Do you guys remember that rule? Did we talk about that? We just take the decimal place and move it one over to the right. So if I had like a 1% solution, you could just move that over to the right and it would have 10 milligrams per ml of the drug. I think we covered that briefly, right? Maybe. Getting a lot of looks like I have 3 heads sprouted recently. Anyway, that is a good rule to remember. So the same thing goes here. So for instance, if I had D10, that means it's a 10% solution. Dextrose 10% in water. If I move that decimal place 1 over, I have 100 milligrams of dextrose per ml, right? So that's kind of good to try to help you kind of remember your dosing here. D50 would be how many milligrams of dextrose per ml? 500, yeah. So basically half of a gram, right? 500 milligrams is half of a gram, and basically every ml of that dextrose there. So again, usually what your dose is 0.5 to 1 grams per kilogram, and so we usually try to limit that to 25 grams in that case. So that's kind of our usual dose. Try to give 25 grams. So if you have something like D50, usually that will come. You'll see that a lot, like in crash carts and things in the ER. We'll have syringes that are kind of preset up to inject big doses, like 25 grams essentially of dextrose into a patient very quickly. If they come in and we see they're hypoglycemic, we see they're unconscious, anything like that will be a quick way we can try to reverse that. Be careful, especially with children. High dextrose concentrations tend to cause a lot of inflammation in the veins. Thrombophlebitis can happen here. And so usually, like for little kids, we'll do like a D10 solution, D25 solution. However, for like adults, you can usually get away with using a higher concentration like D50. Especially if they're unconscious, they're in a code sort of situation, D50 is totally fine for those patients. But little kids, try to use something less concentrated. So there's another drug we can give. It's called Glucagon. Anyone ever heard of Glucagon before? Oh, it's almost like something we make ourselves, right? So we can actually give exogenous Glucagon. There's a recombinant form that we can give. It actually help to stimulate glycogenolysis in the liver. Will help to stimulate gluconeogenesis there and raise our blood sugar. Another kind of interesting thing here is it actually has some smooth muscle relaxing effects in the GI tract. So we actually can see that in the lower esophageal sphincter. It can loosen that tone there. That can be useful because sometimes if you have a patient who has a foreign body they've ingested and it's kind of stuck there right at the pylorus there, we can actually give them some glucagon and sometimes help stimulate that to push through. Normally, general rule of thumb when it comes to foreign body ingestions in little kids is that if it's caught in the esophagus, you need to go in there and get it out. If it's kind of past that and it's gone to the stomach, usually you can kind of let it ride and just collect it in the feces later on. There's some exceptions to that, but that's kind of the general rule. So sometimes especially if you're in an ER in the Friday night and the GI doc doesn't want to come in to scope the kid, they'll be like, give some glucagon. Let's see if it passes first, and then if it doesn't, which normally doesn't, then they have to come in and then scope the kid. So anywho, something you might see out there. Yeah, so one thing to remember though is that you need to have glycogen around in order to have this work. If you don't have any glycogen, this isn't really going to do a whole lot of good. So patients who have kind of acutely become hypoglycemic, they probably still have some glycogen stores around. Maybe they just need a little help with that little extra glucagon. However, if they've been hypoglycemic for a long period of time, they've been down for a while, they may not have a ton of glycogen, this may not work. In which case, what's your backup? Just give them dextrose, right? So just give them the sugar in that case, okay? This does cause a lot of nausea and vomiting, so just be aware of that. You may want to pre-dose with what kind of drugs could I use? It may come up on the test on Monday. Zofran's good. Anything else? Phenergan, Reglan. Any of those drugs are fine. Any kind of nausea and vomiting medication would be good for that. We usually have to pre-dose it because, again, what else could a person who's hypoglycemic potentially do? You also get nauseous and throw up, right? So again, this would be something you want to watch for. All right. So typically when you're looking at your treatment goals for a diabetic patient, typically you like to your A1c less than 7%. That would be beneficial. And then you're also looking at things like your pre-prandial and post-prandial glucose here, right? So you're looking for your fasting glucose where it should be at, and then the post-prandial should be less than 180 or so. I'm not going to ask you on this specifically, just kind of give you some guidelines here so we can kind of see where, when we're deciding what drugs to use and things like that, we can kind of go back to this. Depending on which organization you're looking at, they may have a little bit more stringent requirements here. I think this should have said 6.5 if I had to guess. Normally I don't like to leave hanging decimal points there, but anyway, so you might see different recommendations depending on which organization you're looking at, but they're kind of in the same ballpark from that standpoint. So kind of moving over from type 1 diabetes, which again, the only treatment for type 1 diabetes is insulin, right? So again, we're not a whole lot of room for a lot of these other type of drugs, but now moving into type 2 diabetes, we'll see a lot of new drugs that we can use to help utilize the insulin that we're producing a little bit more effectively. So again, obviously we like to use lifestyle changes if possible for these patients, but that frequently will not fix the problem by itself. Some patients will, but not everyone. And then we're going to deal with monotherapy. Usually, if that does not work so well, and we'll look at which drug we like to go with. In general, we have to go with first. We'll utilize combination therapy of oral drugs, and then if that still is failing, then we can start to utilize combination therapy with some of our parenteral medications. Look at some of the new ones that will be given via sub-Q route, but then also insulin. So kind of the end therapy, if you kind of fail everything else with a type 2 diabetic patient, you still fall back to insulin. You can always give them insulin. That usually will correct the issue. You just may need a metric ton of insulin to fix some of these patients. I've seen, especially those patients are getting like U500. You can just massive doses. You can still overcome it with numbers, but again, you like to avoid that if possible. Because again, there's side effects associated with insulin. You worry about hypoglycemia. What other kind of common side effect may be problematic for a type 2 diabetic patient with insulin? What does that normally do to your weight? Normally it goes up, right? So again, what's probably their baseline problem with type 2 diabetic anyway? They're probably obese as well, right? So again, you can kind of see how this will compound the problem here. So, and we'll see there's a couple of drugs here that can actually help to reduce weight and actually be very beneficial to some of our patients. We'll look at some drugs that you can actually use off-label to help kind of get their weight down as well. Anywho, so looking at someone who has kind of normal glucose tolerance, someone who has impaired glucose tolerance, kind of a pre-diabetic sort of state, and versus someone who actually has full-blown type 2 diabetes. You can see here, obviously, their plasma glucose levels, obviously going to be higher for the type 2 diabetics, going to be kind of in between for the impaired glucose tolerance. The other thing, though, to note is you're looking at their insulin levels. Normally, what you would see is with a normal glucose tolerant sort of patient, you see their insulin levels kind of peak up around mealtime, and then after a glucose bolus, and those should go back down pretty normally, right? So this is what most individuals would do without diabetes. What you're going to start to see with the impaired glucose tolerance is you're going to have these higher levels just sticking around for longer because they have a harder time getting that blood sugar back down, right? So you need more insulin around for longer. We're going to see there's going to be some issues with that. This helps to kind of wear down the pancreas over time. And then what do you kind of notice about the type 2 diabetic patient? They're releasing less insulin than the person with impaired glucose tolerance. Why do you think that is? Starting to wear out the pancreas, right? So they're starting to see destruction of more of these beta cells, and eventually to a point where they're going to need exogenous insulin to replace what they're not able to produce anymore, right? So this is one of the things you're going to see, and they're still producing some insulin, but again, maybe not as much as they used to, and so we're going to see some drugs that can help to utilize that insulin a little bit more effectively. Other things we're going to see is that glucagon levels tend to stay higher with patients with type 2 diabetes. Normally, if you had a person with normal glucose tolerance, you'd see with glucagon, because again, when you have increased insulin levels, what does that normally do to glucagon? Normally suppresses it, right? So they have kind of a seesaw sort of effect on one another. So when you have, a normal glucose tolerant patient have a big spike of insulin, normally you should see their glucagon go down to pretty negligible levels, which makes sense as that normal negative feedback loop we've kind of talked about before. However, with a type 2 diabetic patient, you normally see glucagon levels will be higher. And what does glucagon normally do to your blood glucose? Increases it, right? So the patient's kind of fighting themselves. So we're going to look at a few drugs as well that will help to get those glucagon levels down in order to help kind of regulate the blood sugar a little bit better. Okay. Things to keep in mind. So here are the different classes of medications we're going to use to treat a type 2 diabetic patient. We're going to have drugs that stimulate the pancreas to make more insulin, so we can try to help to kind of kickstart the pancreas to spit out more insulin than it would normally. This is where we're going to see our sulfonylureas and also a group of drugs called the meglitinides. We're going to have drugs that sensitize the body to insulin. So this also helps. So not only are we going to have things like our skeletal muscle be more effective at taking up insulin or taking up glucose in response to insulin, we'll also have the liver to become more sensitive and to not produce as much glucose. It can be very useful. This is where we're going to get our thiazoledinediones, otherwise known as TZDs, as we'll see it abbreviated, and then also our biguanides. This is where metformin comes into play. Who's heard of metformin before? Probably most people who've had any kind of encounter with a diabetic patient probably heard of metformin. We're going to have drugs that slow down the absorption of starches. So these would be our alpha glucosidase inhibitors. These actually prevent breakdown of sugars within the GI tract and prevent absorption. Then we're going to see things that can help to suppress glucagon, so kind of what I was just talking about a second ago. Decreased gastric emptying, decreased food intake. This is where we're going to be our incretins. These are actually going to be glucagon-like peptides. These are going to be products that try to stimulate glucagon and some of its congeners. So we'll see some examples of that a little bit later. And then our newest class that we have here are going to be these ones that decrease reabsorption of glucose from the renal tubules. And these are going to be SLGT2 inhibitors. Again, we're going to go into detail on these in a second. But yeah, so remember, whereas glucose normally gets filtered at the glomerulus and then it gets reabsorbed where at in the renal tubule. And yeah, usually in the proximal convoluted tubules, a lot of that gets reabsorbed, right? That's where a lot of that bicarb and amino acids and glucose all get reabsorbed right there. You can actually block that, and you can prevent that from being reabsorbed, and then it all just be excreted out into the urine. Can anyone think of any issues that might arise from that? Yeah, UTI. So actually, fungal UTIs tend to be a problem with some of those patients getting this drug. So we'll look at that in more detail in a second here. Because again, more sugar around, more bacteria, more fungus, things like that like to chew on that, and then we'll kind of start an infection. So anywho, so just in general, this is kind of an old slide here, doesn't include all the groups, but you can kind of see, based on the different classes here, the general expected reduction in things like fasting plasma glucose, and then also the A1c reduction. So again, not all these are going to be created equal. However, we're going to look at some of these in more detail, just to kind of give you a decent idea. We'll look at kind of like first line, what you're going to go with most of the time, and then we'll look at a plethora of options. You can kind of add on to that. And the nice thing with a lot of diabetic medications, they usually come in combination forms. Because again, how do you increase compliance? Yeah, decrease the number of pills they're having to take, right? Decrease the complexity of the regimens. If we can give them fewer pills to get more drugs into them, then that can generally be better from a compliance standpoint, right? So looking at, we'll talk about sulfonylureas first. So I mentioned these are going to be drugs that help to increase release of insulin from the pancreas. There's a couple of the old first generation agents. The only one I want you to kind of be familiar with is called chloropropamide or diabetes. You don't see it used too often, but again, I've seen it with some regularity, so at least be familiar with it. The more often ones you're going to see are going to be the second generation agents, so glimepiride, glipizide, and glyburide. You'll definitely see these used out there quite frequently, especially in a lot of combination products, along with things like metformin. So looking at how these drugs are going to work, they're going to be blocking ATP-dependent potassium channels. Remember, if you go back to those slides, we talked about how insulin actually gets released from the beta cells. They actually block these potassium channels directly, and by doing that, what does that do to the cell? So it keeps more potassium in the cell. That raises the electric potential, and then what does that do? Sets off an action potential, right? So it's going to depolarize the cell. It's going to cause calcium, voltage-gated calcium channels to open up. That will allow calcium to flow in. And that will eventually lead to the calcium causing the vesicles of insulin to be released. So we're basically doing this directly. So instead of relying on things like glucose interacting with those glute transporters on the beta cells, we're just going to be directly closing those potassium channels. So this is going to cause increased release of insulin. Now, what do you think is going to be a primary side effect of these medications? Hypoglycemia, right? So that's a big thing we want to worry about. Is we'll see some of these drugs. Some of them are going to have a big risk for hypoglycemia. Some of them are not. And so that's important to remember because, again, you need to educate your patients. So again, some things like metformin, you're never going to get hypoglycemia from that. But however, these drugs, you certainly will. So you have to remind to educate them on things like, be careful skipping meals or make sure you have some source of glucose on hand in case you do have an episode, right? So other things you can see is that by having this increased release of insulin out into the system, we're going to be decreasing hepatic glucose production, decreasing gluconeogenesis, which will generally be a good thing to help kind of drive glucose levels down. You should see some increase in receptor sensitivity in a number, so that can be kind of a beneficial side effect of that as well. Have some moderate increase in sensitivity there. And you should also have some suppression of glucagon levels, which again, we saw that was an issue with these type 2 diabetic patients already, right? So again, all good things for our patients. So a lot of these are going to be metabolized in the liver, and you'll have some that have active metabolites that get excreted in the urine. So be careful with patients with renal disease. They'll tend to hold on to these a little bit longer, more likely to see hypoglycemia as a result of that. Remember what we said, insulin is also eliminated via what route? Partially through the kidney as well, right? So remember, when you see renal failure, you're also likely to hold on to insulin more, see more likely risk for hypoglycemia. So remember that. So just be careful. You have a patient with renal or hepatic dysfunction, they can't hold on to these drugs for longer than they expect, and you can see some hypoglycemia. So be careful with that. Now, we mentioned kind of the drug of choice for pregnant patients with gestational diabetes is what? Insulin, yeah. So you'll see, obviously, lifestyle modifications is the #1 thing, but insulin will also be kind of the safest route because again, it's kind of the most natural substance that you can give because the mom should be producing it anyway. You may see sulfonylureas used occasionally, but it does cross the placenta, and there's some risk for depleting fetal pancreas supplies of insulin. So because of that, you usually avoid this one, but maybe one you see used in kind of treatment-resistant patients. Okay. Now chlorpropamide we don't like to use in elderly patients because it's pretty long acting. It has a half-life around 48 hours or so, or is the duration of that. So much more likely to see hypoglycemia. And again, along with insulin causing hypoglycemia, what else can it cause kind of long-term? Weight gain's the other big thing you're going to see with that. So again, if they're already obese, it can be worsened by this drug as well, just like insulin could do it. You could see a disulfiram reaction with alcohol. Remember what other drug typically causes a disulfiram reaction? Yeah, Flagyl is the other big one that does that, right? Okay. So chlorpropamide and glyburide are the most likely to cause hypoglycemia. If you have a patient with like liver or renal dysfunction, maybe switch over to something like glipizide, glimepiride might be a better option for those patients. Okay. So again, I'm not going to go too much in detail on these specifically. Again, you can usually see when you're using drugs like this in conjunction with exogenous insulin, you can actually drive down your insulin doses that you need because you're making the beta cells work a little bit more, or at least not more efficiently necessarily, but just get in kind of more kind of overdrives kind of situation, producing more insulin than it would normally. But again, more likely to cause hypoglycemia than a lot of the other options we're going to see here. Let's see. Usually the glipizide is going to be in an XL formulation, so this one's actually kind of interesting. If you ever see a patient actually complain of seeing a tablet in their feces, this is totally normal when you're doing a glipizide XL. It's kind of cool because it's a tiny tablet, and you can look up pictures of this, but it has a tiny hole that's actually drilled into the center of it. And basically what happens is via osmotic pressure in the GI tract, it actually forces drug out of the tablet slowly. So the tablet never actually breaks apart. It just has this tiny hole that's kind of slowly releasing it. So they'll see the tablet in the feces. If they see that, it doesn't mean the drug's not working. It just means that's how the drug was designed in the first place. So again, could be a little education point to remind your patients about. Right, so we mentioned hypoglycemia being a big risk, weight gain. Can see some, kind of moderate GI effects here. Very rarely would you see any kind of blood dyscrasia. It's not super common with that one. And you may see resistance develop over time to these drugs. Why do you think that would be? Because again, as you have further destruction of those beta cells, if you have less insulin to release in the first place, these drugs are not going to, they don't have any good beta cells to work on. It doesn't matter how much you give, it's not going to be able to send out any more insulin. That makes sense, right? Okay. So again, be careful. You normally think a patient with DKA, they have an insulin deficiency. This would be a contraindication because again, you need to give them exogenous insulin to fix their issues there. Again, we don't want this for type 1 diabetic patients because why? Yeah, they don't have any insulin to produce themselves, right? So again, these drugs would be completely ineffective for those patients. There'll be some examples where you may use some of these type 2 diabetic kind of drugs for a type 1 diabetic patient. I'll mention that briefly in just a little bit, but this is certainly not one of them because again, they don't have any insulin to release of their own. Right, so just be aware of that, and then we talked about some of the drug interactions there. Again, if you mix this with other drugs that can cause hypoglycemia, just be aware of that because that can again be kind of synergistic. So if you mix this with insulin, higher risk you're going to see hypoglycemia, right? So just be aware. Okay, so then kind of similar to the sulfonylureas, you're going to have the meglitinides. There's two ones here. We don't use these as often as the sulfonylureas. We may see them occasionally. There's repaglinide and nateglinide. Basically, these are doing a very similar action to the sulfonylureas in that they're going to be closing those potassium channels. However, these are going to be sort of glucose dependent. And so what I mean by that is that they really only work around mealtime, kind of big influxes of glucose into the system. If you take this at a normal kind of resting state, you don't really see a whole lot of increase in insulin release. However, if you just ate a big meal, you have a lot of glucose coming in, this will stimulate further release of insulin, more so than it would be if you did not have one of these drugs on board. So as you might imagine, when do you think you would take these? Around mealtime, right? So again, they're going to be working best when they're around mealtime when you're having a sudden influx of glucose. So things like, repaglinide within 30 minutes, nateglinide even shorter than that, 1 to 10 minutes before you eat. And that way they're going to have, peak effectiveness around that first hour or so after you eat, and then, it lasts about 3 to 4 hours. So again, not as potent as you would see with the sulfonylurea, which kind of works at baseline kind of around the clock. However, these may be used occasionally in combination with things like metformin. But just remember that if the patient skips a meal, you should probably skip a dose of this as well, because the drug really won't be that effective. Again, very similar side effects to what you saw with the sulfonylureas, again, because they're doing kind of the similar action there. Just usually less likely to cause hypoglycemia than sulfonylureas, but still a definite risk. Okay, so next up we have the biguanides. There's really only one from this category you need to be familiar with. This is going to be metformin, or glucophage. You may see it be called glucophage XL. Glucophage, doesn't really matter how you pronounce it, but metformin, very, very common drug. This is usually the first line drug that most type 2 diabetic patients will get started on. Okay, it's good to remember. Usually the first line drug they'll get started on. Some of these were removed from the market because it can cause a fatal lactic acidosis, which is another important, unique point to remember about metformin. So we'll talk about that in a second here. And this is one is usually seen in combination with other drugs, so things like metformin plus glyburide, metformin plus glipizide. We'll talk about rosiglitazone in a little bit, but you'll usually see metformin in combination with other things as well, or by itself. So this one doesn't have a really kind of specific mechanism. It kind of does a lot of things throughout the body, which is why we like it so much, because it has a kind of a wide-ranging set of effects. Really helps out quite well with these this insulin resistance these patients are developing. So, for instance, it helps to decrease hepatic glucose production. That's good because it should drop our glucose levels. It will increase peripheral uptake and utilization. So basically, things like skeletal muscle will become more sensitive to the insulin that the body's already producing. So that can be beneficial to help kind of utilize insulin more effectively, which is why we call it an insulin sensitizer. It's kind of the term we use for metformin because it helps our insulin to work better. You also see less glucose absorption from the GI tract, and in conjunction with that, very limited hypoglycemia. It's very rare you would see someone who is just taking metformin by itself have hypoglycemia, right? The body is better able to regulate itself than, as opposed to something like a sulfonylurea, where you're causing the pancreas to send out more insulin. This kind of avoids a lot of that and just really helps to utilize insulin more effectively. So one thing to note here is that the drug itself is not metabolized within the liver. However, hepatic disease is going to be a contraindication to receiving metformin. The reason for that is because of lactic acid buildup that can happen in conjunction with metformin. Normally, lactic acid gets broken down in the liver. You can eliminate that and get rid of it very easily. If you have hepatic dysfunction, you can build up levels of lactic acid. And does our body like lots of lactic acid around? No, not so much. You get very significant lactic acidosis, you get hypotensive, you're very, very sick. I've seen several patients, usually older patients, who've been on metformin for years, have something kind of tips them over the edge. They're not able to clear that lactic acid, and they've seen several deaths associated with that. So be very careful with that. And in fact, you're going to see there's actually going to be the other way that lactic acid can also be cleared is through the kidneys. You're going to see in a few seconds here that there's actually a serum creatinine cutoff for utilizing metformin. So usually this gets excreted unchanged to the kidney. So again, if you're not holding on, or if you have poor kidney function, you're going to hold on to more metformin. That will increase your risk for lactic acidosis as well. So be aware of that. And we'll talk about the cutoff for renal impairment there in just a few minutes here. So again, this is also going to be good for patients who are obese, who have insulin resistance, because this actually has either no weight gain or actually a little bit of mild weight loss. So it's kind of beneficial there for your patients. You're utilizing insulin more effectively, not causing them to increase more insulin release. So you don't really see any weight gain. Again, maybe a little bit of weight loss could be beneficial for obese patients. So this does cause a significant amount of GI side effects. So sometimes you can drive your dose up of metformin pretty high for the most part. You can take several grams a day of metformin, but the GI side effects usually kind of limit that. So we do things like use an XL formulation, so that way you can kind of have kind of more slow release throughout the day. It can be beneficial. But a lot of constipation, diarrhea, nausea, vomiting associated with it. So be aware of that. But then the lactic acidosis, more likely to see in renal impairment, and especially patients who are older, especially patients who have had surgery recently, because again, sometimes after surgery you can see kind of a transient decrease in renal function, so you can see some issues with that. Usually this is one of those drugs where we'll probably discontinue it while they're in the hospital, especially if it's a very short course, and then you can restart them when they go home. It's usually not a problem. And then some risk for having decreased B12 absorption, so some risk for megaloblastic anemia. I don't know how common that actually is, but it is a reported risk. You may want to supplement with extra B12 for those patients. Okay, so here's contraindications for the biguanides. Remember, if they have GFR less than 30 mLs a minute, which is pretty significant renal dysfunction. What's a normal creatinine clearance? Usually over 100, right? Even 80 might be a little bit on the low side, but around 100 or so, you consider it's probably good creatinine clearance. Less than 30 though is pretty significant of a decrease there. They used to make old recommendations based on certain serum creatinine values, but nowadays it's just based on the actual GFR. How do you calculate GFR? You remember what we talked about? That Cockcroft-Gault equation that we mentioned, right? You had to plug in the patient's age and their serum creatinine and their weight, and that would give you basically what their estimated creatinine clearance is. So, right, so nowadays we're doing that. So you calculate if less than 30, you probably avoid metformin just because that risk for holding onto the drug and getting lactic acidosis is too high at that point. Certainly if they're hypoxic, again, that can kind of shift you over to being more acidotic. You want to avoid that. And I mentioned, kind of stopping it before surgery. Usually kind of withhold the drug 48 hours or so after surgery, because again, also surgery, you can see some increase in lactic acid levels, so you don't want to be careful with that as well. There's also another thing we'll talk about later on, the nephro section. With contrast, whenever you receive contrast for imaging purposes, you can't have a transient decrease in renal function. So this is another case where you want to stop metformin in order to prevent any kind of buildup of that drug and risk for lactic acidosis. But we'll talk about that later. All right, any questions from the first half? Feel pretty comfortable with their insulin? So if a question came up on a test, like which one would I use, which one would be appropriate to use around mealtime, to delineate that, or if I asked, which combination of these would be more likely to cause hypoglycemia, that'd be a good one to ask. Just trying to think of ideas at the top of my head. Not like I'm writing your test right now or anything, but just thinking things. Anyway, all right, next up we have the thiazolidinediones. I don't know why these people name these things these ways. They're way too difficult. Anyway, TZDs, we will oftentimes abbreviate this TZD. So if you see that, that's what I'm kind of referring to. I will probably write both. If I were to ask this on a test, I'd write out the whole name and then TZD in parentheses, so at least that way you're at least familiar to seeing it. Two big ones here, and some of these are kind of going out of vogue. These are kind of like a big deal for a while, especially in use with metformin. But we have pioglitazone and then rosiglitazone. So Actos and Navanda. There was a troglitazone as well, but that got taken off the market due to liver toxicity, so we don't use that one anymore. But we have rosi and pioglitazone, and basically how they're working. Kind of a different mechanism completely than what we saw with like metformin or the sulfonylureas, but they're a potent agonist for this peroxisome proliferator activated receptor gamma, or just PPAR gamma. Again, people don't make these things easy for us, right? But PPAR gamma, and this actually helps with some regulation of transcriptions. They're kind of working at the nuclear level for increasing transcription of these insulin responsive genes. So basically by increasing activity of these genes, you have more proteins being made from that. You should see some improvement in lipid and then also glucose metabolism. Okay, so we're getting better activity, better utilization of the insulin that we're already producing by having activation of this PPAR gamma enzyme. So basically what we should be seeing when you administer one of these glitazones are going to be increased peripheral glucose uptake and increased utilization. So you can see very significant increase in sensitivity to insulin, which is what our main problem is with these type 2 diabetics typically. And you should see some different decrease, and this should say actually glucose production. I don't know why I put insulin there. Obviously, glucose does not make insulin, right? Right? Yes, you guys know that. So you should see decreased hepatic glucose production. That should be what that says there. Basically, you're going to find that they are going to be metabolized at the liver. You may need to wait a couple of weeks before I actually see full effect. And that kind of makes sense based on what we're thinking of. Like sulfonylurea, like when should you see the effects kind of kick in? Pretty quickly, right? Because again, they're going to go and close the potassium channels, increase insulin release pretty quickly, right? This, because we're working on the transcription sort of level, we're dealing with things like, regulating gene transcription, takes a little bit longer. So we may need to take a few weeks before you really start to see the full effects of these drugs. However, there's going to be a reason why they went out of vogue, as we'll see here in just a second. One of the things you see is that you can actually have expanded blood volume, edema, and actually worsen heart failure. So there was some risk of increased cardiovascular death associated with using the glitazones. I think specifically rosiglitazone was the one that got a lot of the hits on that. At least a lot of the evidence was being shown. There's increased death associated with it. So certainly, a heart failure patient would not be a very good candidate for one of these thiazolidinediones, these TZD drugs, because again, it could worsen that, worsen edema. kind of generic side effects here, you know, muscle pain, some headache, fatigue. May see a little bit of weight gain with this one, so this again would not be as welcomed in an already obese patient, right? Could be offset by things like, you know, metformin potentially. We'll have some negative effects here on, you know, positive effects on HDL, but you will see some increase in LDL, you know, a little bit there, and then kind of variable effects on triglycerides. So again, if they're already having hypertriglyceridemia, maybe this may not be the best option, but you have to take it with, you know, kind of monitor it over time when you're doing that. The other big thing to do is make sure to monitor for liver dysfunction. So again, because we know triglyceridone was taken off for causing liver failure, there's still a risk with one of these drugs, and so you have to monitor for that. So just again, you know, looking for things like you know, ALTs that are 3 times the upper limit of normal. And once you start to see kind of big increases like that, that's when you want to probably consider taking the patient off of that medication and switching over to something else, right? So basically, this is again, I'm not gonna have you memorize any of this, but basically, when they were looking at risk of MI and cardiovascular death associated with rosiglitazone, so that's, you know, one of the ones we were talking about there. They actually found that, you know, and again, we can exercise our epibiostats knowledge, right, of being able to interpret the literature, correct? So let's look at this. So again, if we're looking at MI and we're looking at, say, like this DREAM trial, notice that most trials are simply designed, their names are just made to make a good acronym, you know, even though they may have some pretty odd, if you actually like spelled it all out, it's pretty odd grouping of words, but like it says DREAM though when you abbreviate it, so it's great. Anywho, so again, when they're looking at the control group versus the rosiglitazone group, it's on odds ratio of 1.65 for causing MI and cardiovascular death, but was this significant? No, why is that? How can you tell? Like, oh, the p-value is too high. I can tell that. But you don't even need the p-value. Remember, you guys don't need p-values. You guys are pros. So if you were looking at that, why does it not significant? Yeah, remember it crosses 1, right? Because we're talking about odds ratios. So odds, you start off at 1, and then if it's greater than that, if it encompasses 1, then it's non-significant there. However, what they were finding though is that when you're looking at overall, when you combine several trials together, they did see an increased risk, right? So 1.43, this was significant because it did not cross 1, and then we see the p-value kind of backs that up. So that was for MI specifically, and then we're looking at death from all cardiovascular causes. Again, we saw you know, some trends toward association. Like here, the small trials, they definitely saw an increased risk. However, you know, oftentimes what you'll see in the literature is even if something doesn't actually show significance, they'll say it trended towards significance. It kind of went towards that direction, and that may be enough to say, like, well, this looks dangerous enough. Perhaps if we had more people to look at, more large studies, perhaps we might see that actual difference being there. And again, when you don't find a difference, when actually is there, what do you call that? Type 1 or type 2 error? It's a type 2 error because, again, you didn't find a difference when one was there. That's a power problem, right? You need more people in order to have more power to show the differences there. So, again, I won't test you for that on the test, but these are things you should be thinking about when you're doing your literature reviews for your research methods class, right? Trying to integrate it all together, guys. Anywho, so right, so there's some increased risk here. So because of that, when you kind of compare it to other drugs for type 2 diabetes, it really didn't see that same associated risk. So that's why the glitazones are kind of going out of vogue. You still may see pioglitazone being used occasionally, and that's, you know, did not get shown to have the same effects as Rosie, even though we don't really know if it's a class effect or not. We just don't have the trials to show it. So in general, be careful when you're using it for especially patients with CHF. And again, if they have a high risk cardiovascular risk history, I'd probably avoid using those TZD drugs for those patients. Okay, so that's kind of the takeaway there. Next up, we have the alpha glucosidase inhibitors, and so these are going to include acarbose and miglitol, and so this is going to basically be inhibiting glucose metabolizing enzymes within the GI tract. So we'll inhibit alpha amylase, alpha glucosidase, basically decreasing the amount of glucose we're absorbing. So what do you think happens to that glucose that's left over in the GI tract? Who likes glucose? Likes people. Bacteria love glucose. What do they turn glucose into? They break it down and they produce gases out of it, right? Because again, eventually glucose gets broken down in carbohydrate, CO2 and water, right? So they start to produce all that gas, right? What happens do you think all that gas? It's going to have to come out of your patient somehow, right? So we're going to see that there's a lot of GI discomfort associated with these. We're going to see there's a lot of, these are not super well tolerated by your patients because of all that excess gas, right? You're going to be seeing a lot of flatulence associated with this. You're going to see some eructation, right? You know what that is? Yeah, belching, right? That's a very fancy word for that. I always like to use fancy words for kind of benign sort of things. I don't know what borborygmus is. It's like your stomach rumbling, yeah, so. Anyway, so again, these drugs though are beneficial because they actually don't get absorbed from the GI tract. So these could be potentially safe for things like pregnant patients if you're worried about drug exposure, because they don't get absorbed. They're not really going to have any systemic effects from that standpoint. They're really only working directly in the GI tract. Need to be taken with the first bite of every meal because again, if there's no glucose kind of actively in the GI tract, there's nothing for it to really work on. So it needs to be taken with meals. So again, now we've seen two classes of drugs that have to be taken with meals to have maximal effect, right? So we see that our meglitinides have to do that, right? Because sulfonylureas are going to be mealtime independent. And we also see if these alpha glucosidase inhibitors. Remember any other drugs we had previously in this section? Not like endo, but in this whole section of the class that also need to be taken around mealtime? Or PPIs, remember those are going to be more active on actively secreting proton pumps, right? So little things to keep in mind that may show up sometime soon. Who knows? Anyway, so again, just be careful with these drugs if you know, you have patients with kind of history of like, you know, GI issues, you know, if they have like Crohn's or ulcerative colitis, and maybe worsen by having all this extra glucose being interacted with those bacteria. May not be great for them, but in general, pretty safe for the most part from a kind of a systemic standpoint. So, as you mentioned, a lot of diarrhea associated with this, a lot of flatulence due to those undigested carbohydrates that are in the colon, a lot of abdominal pain. And so, again, watch out to have inflammatory bowel disease, any kind of GI obstructions, chronic intestinal disease. These are things you want to avoid typically. Okay, so those don't get used to too often. Probably the most common one we've seen used so far now is going to be metformin. Most patients should be started with metformin unless they have some other contraindication. Like what would be a good contraindication for metformin? Kidney disease. Liver disease is the other big one, right? Because you worry about that lactic acidosis, right? So in general, though, most patients should start with metformin. They can utilize combination drugs like sulfonylureas. You know, they can utilize an alpha glucosidase inhibitor. They can utilize potentially a glitazone. Now we're starting to see some of these newer drugs that are going to be working on different mechanisms on different hormones here. So one of the things we're going to see is this hormone called incretin. Did we mention incretin in physiology? Anyone remember back that far? That somewhere was a blur to me as well, but I'll have to review the slides soon, so I'm pretty sure if I see incretin, I'll be like, oh, those guys knew what I was talking about. But anyway, looking at plasma glucose, normally what you're going to find is that it's kind of interesting. So looking at oral glucose versus an intravenous glucose administration here. So if you were to look at blood glucose levels, you really shouldn't find a big difference between oral glucose and IV glucose. So again, if I were to give you a bolus of IV glucose and then your neighbor an oral glucose bolus, the blood sugar rise should be relatively similar if we did a similar dose based on weight, right? That kind of makes sense. However, if you're looking at this hormone called incretin, you're going to notice here that it really spikes up with the oral administration. That makes sense because when we're orally taking in food, you're going to find that there's that whole kind of enteric nervous system that is going to be involved with that. We know there's a lot of communication between our CNS and we see a big juicy hamburger coming to us and communicating with our enteric nervous system. We see there's a lot of communication there. And incretin is going to be really important for helping to regulate a lot of that increased glucose is going to be coming into the GI tract. So normally what you're going to see with our incretins, we have one called glucagon-like peptide. Pretty short half-life here, but typically what you're going to find is it's stimulated by after-meal glucose. So you have a big spike in your blood sugar, starts to get above 90 milligrams per deciliter, you start to see this GLP-1, which is another way to reference that, start to increase in levels. Basically, these are coming from these L cells of the intestine. And you're also going to find this glucose-dependent insulin release that will help to increase secretion of that, right? So GLP-1 goes up, you're going to find increased release of insulin from the pancreas, and that makes sense because our blood glucose is going up. That should be kind of a downstream effect of that. And will also help to decrease gastric emptying and food intake. So incretin is one of the things that actually help to suppress the urge to have more food and will help to decrease actual gastric emptying time. And so that kind of slows down the amount of glucose that's available to be absorbed and will just kind of slow the whole process down overall. So not only that, but GLP-1 will also help to increase gene transcription of insulin, will help to increase release of that, so it's very beneficial to helping increase insulin amounts. And then the other thing to note here is that it gets broken down by an enzyme called dipeptidyl peptidase 4 or DPP4, okay? So we're going to look at incretin mimetics, which are going to be things that try to simulate the effects of GLP-1, and we're also going to look at things that help to prevent the breakdown of GLP-1 by interacting with that DPP4 enzyme. Everyone with me so far? So incretin good. You're going to find that GLP-1 is good, but you may find that we have blunted levels of that in type 2 diabetics, as we'll see here in a minute. So again, GLP on secreted, get secreted when you have ingestion of food. You're going to find this helps to increase insulin release. It helps to promote satiety and reduce appetite. So what do you think is going to be an effect of giving these? Weight loss, right? So if you don't feel like you need to eat as much, then you're probably not going to consume as many calories. calories in, calories out, you're probably going to end up having some weight loss associated with that. That's important because this is going to be where some of these are being used off-label nowadays for weight loss purposes. We'll look at that in a second. And again, a lot of your diabetic patients, type 2 diabetic patients, are obese, overweight, they're obese, so this can help with that pretty significantly. This will also help to decrease glucagon secretion, will help to decrease the amount of glucagon, reducing the glucose output, right? So less glucagon means we're having less glucose coming out of the liver, and also helps to regulate the gastric emptying. So these are all good things for our patients. You're going to find the GLP-1 typically goes down when you have a type 2 diabetic patient, right? So also, they're going to have that increase in glucagon release after meals, as we saw in that slide in that graph a couple slides ago. You saw the glucagon levels stayed high for those patients long after where it normally would have been for someone who had normal glucose tolerance. Okay, so basically, we need to do something to try to help to increase activity of GLP-1, either by replacing it, by giving an exogenous form of it, or by preventing breakdown of GLP-1. Which one do you think would be ultimately more potent? Replacing it or trying to prevent breakdown of it? We're going to find that replacing is going to be ultimately more effective. However, when we're looking at how we can give those drugs, we're going to find that typically it's going to require administration of a protein. GLP-1's a protein, right? So how would we have to give that protein? Typically parenterally, so usually subcutaneously, versus we're going to find there's some tablets, some oral options that we can use to help prevent breakdown. The DPP-4 inhibitors we'll look at in just a second here. So again, looking at, going back to that slide I kind of mentioned there, that normally when you have a glucose or a type 2 diabetic patient, normally glucagon levels stay pretty high here for a lot longer than you see in a normal glucose tolerant patient. And so we're trying to increase GLP-1 activity to try to get these levels down, because again, it's going to help to decrease the amount of glucose that your liver is producing, because again, when you're eating food, you probably don't need the glucose to come from your liver. It's coming from the GI tract. So we're going to try to help regulate that by fixing this issue here. Okay. And then looking at GLP-1 secretion, when you have a patient who has breakfast here, you're going to find that with type 2 diabetic patients, typically it's a lot lower than someone who had, say, normal glucose tolerance. So again, we know those levels are lower in these diabetic patients versus someone who is otherwise healthy. Okay, so anyone know what this is? The Gila monster. Why did I put a Gila monster here? This is actually where we get some of our incretin mimetics. So the saliva of the Gila monster actually has a lot of homology with GLP-1 for whatever reason. I don't know if there's some evolutionary branch of the tree that we maybe had a cousin on somewhere, who's to say. But we have a lot of homology there, which means there's a lot of shared amino acid sequencing between GLP-1 and the saliva obtained from the Gila monster. So again, a very odd source for some of our medications, but pretty cool. And so basically, this, the first one we had here is called exenatide or Byetta. Okay, so exenatide. And so basically, this was being used for type 2 diabetic patients who were usually on metformin already, or sulfonylurea, or some combination thereof, and they were not getting their glucose under control. Their A1c was still high, their fasting glucose was still high. They need something else to help them get this in control. This is where this can be a very beneficial adjuvant to that. So be a good kind of third drug to maybe add on, second or third drug to add on to that regimen. And it can also help with weight loss. So notice here, this one is given twice daily as a subcutaneous injection, and it normally comes as like pre-filled pens. So again, this is going to probably come up on some of your prescriptions assignments, right? I don't remember if I put this drug specifically. I think I put Victoza or something. Anyone remember what I put? Victoza. Yeah, liraglutide or Victoza, I think. So yeah, so again, these are going to be subcutaneous injected products. So again, they're proteins. Usually they'll come as pens, and that will help to kind of make it easier for your patients to administer. They can just put the pen needle on, administer it, and they're kind of good to go. Anyway, so looking at giving exenatide, it actually helps to restore the kind of this, what we call this first phase insulin response. So again, when you're looking at insulin, say normal resting glucose levels here, you give IV glucose, you're going to see the insulin spike up here. And then when you had someone who was receiving, say a type 2 diabetic patient, someone who had a placebo, you can see it's very blunted effective insulin release in these patients, right? They weren't releasing enough insulin. However, when they gave exenatide, saw something that looked very similar to what a normal healthy control patient would look like. So we see that by doing this, we're replacing the GLP-1 that patient's not producing anymore and helping to increase that insulin output, which is, again, good for our patient. Helping to increase satiety, hopefully decreasing calorie intake, weight's going to go down, which will also have some downstream effects to help their diabetes as well. So adverse effects, again, you can see a lot of nausea and vomiting. This makes sense because we know it's slowing down gastric emptying time, so you may see some increased GI upset, nausea, vomiting associated with that. And then there is some risk. Typically, they don't cause a lot of hypoglycemia by themselves. However, if you add this on with the sulfonylurea, the risk is higher, which makes sense because we all of a sudden have mealtime, you're going to see a lot more insulin coming out than what would have otherwise normally occurred. And then we may see some delayed absorption of other oral medications, which again makes sense based on our gastric emptying time being slowed here. Weight loss can be a risk, but again, for a lot of patients, this is not going to be a problem. This can be a very beneficial thing. And then some risk for having pancreatitis. So again, if you think of drug-induced pancreatitis, this is going to be one of those ones you want to start thinking about, because again, we know we're helping to stimulate pancreatic activity, which has normally been blunted in these patients, right? A couple of other ones. So again, these are kind of big, kind of blockbuster sort of drugs now, because again, anything that helps to reliably cause weight loss in patients typically gets quite a lot of Me Too drugs that come on, because again, they're kind of big money makers. So you have liraglutide, which is Victoza. Again, this one has a little bit longer half-life because it actually binds up to albumin, which is kind of beneficial, because again, we saw that having to give subcutaneous drugs more frequently is usually less preferable by patients. So longer half-life drugs is going to be better for these guys. So we have liraglutide, we have dulaglutide, and then albiglutide. Again, usually they're probably just end up calling them by their brand names. But again, it's nice because you don't have to give them, say, subcutaneously once weekly, rather than having to give them, say, like twice a week or every day, anything like that. I actually had my uncle, anyone familiar with Wilford Brimley? Anyone know what he's famous for? Diabetes, right? He did a lot of those commercials for medical supplies for diabetes and things like that, and so he always said diabetes and was very, very catchy sort of way. But anyway, so I have an uncle who is very much like a Wilford Brimley sort of fellow. So imagine what he looks like. Just Google a picture and you'll kind of know what my uncle looks like. He actually went on dulaglutide, this Trulicity, and he ended up like dropping, like, I remember I didn't see him for maybe like a 6-month period. Came back and he had dropped probably like 80, 90, 100 pounds. So again, this stuff can be very, very potent helping to lose weight. However, it can be a double-edged sword, because he's at the point where he's like, I just never hungry, and didn't realize that he's actually getting like malnourished because he wasn't taking enough calories, wasn't taking enough vitamins and things like that. So again, with all things, moderation is key here. Watch their weight, monitor that, make sure it's not getting too extreme, because again, they're just not going to want to eat. That satiety is going to be pretty big with them. They're just not going to have that impulse, right? So that's one way we can replace it, by giving incretin mimetics, kind of another term for those things like exenatide. The other thing we can do is give a dipeptidyl peptidase 4 inhibitor, which will prevent breakdown of those drugs. I'm sorry, of GLP-1. And so we'll also see that they have some kind of ancillary effects here, but this is the primary thing we're looking at, is trying to help increase activity of GLP-1. So we have a few of these here. We're going to have allogliptin, we have sitagliptin, saxagliptin, and linagliptin. Sitagliptin was probably the first one that came out as Januvia, but then again, there's a couple of Me Too drugs that came on here. Typically less potent than what you would see with the incretin mimetics. Still decent drugs though. Probably would not use these in combination with the, or at least maybe in a more severe patient, but typically you'd either see an incretin mimetic or a DPP-4 inhibitor. You don't want to start off with both of these together, because you may see kind of increased side effects associated with that. Again, only things to note here: risk for anaphylaxis is a little bit higher with these than some of the other drugs we talked about. Risk for things like skin rash, Stevens-Johnson. So again, monitor for that. Again, looking at combination drugs here. So again, just showing you the benefit of having combination therapy. So for instance, if you're just using something like sitagliptin 1 time a day versus metformin here 1 time a day, this is absolute changes in A1c in these diabetic patients. You can see here that by using a combination of the two, you can definitely start to see some synergistic effects here. So just be aware that metformin is a good backbone for a lot of diabetic regimens, because again, it's helping to let the body utilize insulin more effectively. You can add on something else like a sulfonylurea, a DPP-4 inhibitor, or exenatide, something like that, and that will get synergistic effects here to try to get their A1c under control. Okay. So again, just looking at some of the differences in activity between a GLP-1 agonist like exenatide or liraglutide versus a DPP-4 inhibitor. The only big things you're going to notice here is that typically less potent the DPP-4 inhibitors are going to be. You won't see as much effect on satiety, really won't see as much weight loss associated with these. However, the one benefit is that they're going to be orally administered. So you can give them as a tablet if the patient is especially hesitant to inject themselves with anything. Oh, there is some risk over time with a GLP-1 agonist to have antibody formation. This doesn't necessarily manifest as anaphylaxis, but could just be an inactivation of the drug. So you may see that it will work fine for a while, and then it starts to wean off in its effect, and it may be because the patient's producing antibodies against it that are inactivating the drug. So that's another thing to keep in mind. If you're like, hey, their A1C is looking good for a while, and then all of a sudden it starts to go back up, could be related back to that. Right. Okay, and then the last group we'll talk about is probably the newest class of drugs we have for diabetics, type 2 diabetics specifically. They're going to be the sodium glucose cotransporter 2 inhibitors, or SGLT2 inhibitors here. And so again, these are probably the dumbest sounding drug names I've ever come across, but I'm going to try to save them for you anyway. So we have canagliflozin, dapagliflozin, empagliflozin, and there's also some combination products you may see being used out there. So again, Invokana sounds a lot sexier than canagliflozin. Like, just doesn't have the same ring to it, right? But anyway, so you're going to see these used occasionally for these patients who, again, you don't want to start with these, but they can be useful adjuncts to add on if, to a metformin backbone or something like that. And basically, they're going to just prevent glucose reuptake in the proximal tubule. They're going to eliminate it through the urine. And so you're going to see that it helps to lower blood glucose because you're just peeing it all out. And then also you're going to see some decrease in weight. Makes sense because, again, you're losing all those carbohydrates through the urine. So, you can have weight loss associated with that. You're just kind of peeing out all the calories, essentially. So, again, adverse effects. Urinary tract fungal infections are a risk here. Around 10% of patients or so are going to develop this, so you can be aware of that. You see some hypotension associated with these patients. And actually, what's kind of interesting is kind of unique effects with canagliflozin specifically. You can see some increased risk for fractures. That actually causes some calcium resorption to occur here. So if you had an osteoporotic patient, perhaps this would not be a good option for them, right? And the other thing you can actually see for some of these patients is this risk for diabetic ketoacidosis, but it's euglycemic. So again, I'm not going to get the full mechanism, but basically, they could have a relatively normal blood glucose, but you would see that it'd actually be developing, kind of switching over to ketosis, probably something to do with insulin release being impaired. But again, it could be a risk for those patients. So just watch out for that. Okay, so this is a good kind of table kind of showing you a decent stepwise approach to approaching a type 2 diabetic patient. Basically, again, you can look at all these drug options and see, okay, well, what's their efficacy, dropping A1C, risk for hypoglycemia, effects on weight, side effects, and then cost. So it's a good way to kind of compare all the different drug options you have here. So like with metformin, efficacy in dropping HbA1c, pretty good, right? So it's a good drug for that. Low risk for hypoglycemia, which we know makes sense based on the mechanism. Weight loss, neutral, probably to some weight loss, a little bit there. And then big side effects to note, GI effects, lactic acidosis, and then usually the cost is pretty low. Okay, which one do you think are probably the most expensive out of the bunch? Probably like those incretin mimetics, like the GLP-1 agonists, are probably going to be one of the more expensive ones because, again, they're proteins. They are, having to be produced in a pretty expensive manner, so the cost gets transferred over to the patient and the insurance company. So, again, metformin, though, it's been around forever. It's cheap as dirt. So that's why it's such a good drug to start with from that standpoint. So again, if you don't get the A1C kind of under control by itself, that's when you can start to use a 2-drug regimen. So again, you can use metformin plus any one of these. So for instance, if you're looking at the ones that have the highest risk for hypoglycemia, you'd look at things like, sulfonylureas. That's what the SU stands for, sulfonylureas. However, a lot of the other ones have pretty low risk. However, insulin, again, would have the highest risk out of the bunch. Kind of makes sense because, again, that's what insulin does, right? Looking at the costs associated with these, looking at DPP-4 inhibitors, looking at the SLGT2 inhibitors, these are brand new, so a lot of these are only brand name. The GLP-1 receptor agonists, again, all these are very high cost. You would see that, maybe this is not a good option for a patient who does not have good insurance that would cover any of these, right? So just things to consider. Look at the unique kind of side effects for each of those categories. These are good things to remember for testing purposes, right? Or like what would be a good combination regimen for a patient that has, hepatic failure or someone who is obese, or we'll kind of have different patient scenarios and try to figure out which drug combination would be best for them, right? And then potentially triple therapy. Once you start getting down to triple therapy is when you're starting to think about things like insulin becoming a more real option for these patients, But certainly if triple drug regimens are not working by themselves, this is when you need to start to think about using like basal insulin. So this is a type 2 diabetic patient will be more likely to go on like, a long-acting insulin in the daytime. So say they'll do a dose of Lantus in the morning, and that will kind of carry them throughout the day. And then they would have maybe maybe mealtime insulin, more or less, probably less likely for a lot of those patients, but at least the basal, and then maybe like a GLP-1 receptor agonist, so something like a exenatide or liraglutide for that. Right? That makes sense? Start easy, start cheap, go with metformin, and then you can kind of add on stuff from there. And again, based off of what your patient's risk factors are, comorbid conditions, cost, things like that. Right? Okay. Any questions on diabetes? All right. If not, I want to move on to a random smattering of endocrine issues and some drugs we can use to treat that. Okay. So hyperprolactinemia, what can we use for that? Oh, anyone know what else we can use metformin for? Yeah, PCOS is the other big thing. To me, help see that. Yeah, you'll find that patients with PCOS didn't have kind of a hyper secretion of insulin. You're going to have a hyper androgenic sort of state. Metformin helps to kind of rebalance out a lot of that stuff. So PCOS patients are probably going to be on metformin. They don't necessarily have diabetes, right? So it may be concomitant, but in a lot of cases it may not be. Yeah. Anyway, just a random thought I had. Hyperprolactinemia. So what can we do for that? Usually you can find that this will be in like prolactin secreting tumors, not satumors, I don't know what that is. Anyone know what kind of drugs could potentially cause this? You guys remember? Dopamine antagonists. Remember, like our dopamine 2 antagonists. So think about like your first generation antipsychotics being kind of the big ones there. Some of the atypicals will do this as well. So again, if you had to imagine, if I block dopamine action, I get increased prolactin activity, what could I do to kind of bring that back into balance? Have more dopamine activity, right? So have a tumor, probably get rid of that, but otherwise, from a drug standpoint, we can have increased dopamine activity. So this is where things like our ergot alkaloids can be very useful for this. So one drug I know I've mentioned before called bromocriptine will be a direct dopamine agonist, and then also there's another one called cabergoline, and these again are high affinity dopamine receptor agonists, and again, a lot of side effects associated with that are going to be related back to things like changes in blood pressure, see things like dizziness, postural hypotension can be associated with a lot of these. So watch out for that. Cabergoline itself has higher affinity, more likely to cause hypertension. So again, just make sure you're monitoring for that. Make sure they are aware of like when they're standing up to just kind of monitor themselves, see if they get dizzy, things like that. Okay, androgens. We talked about the ladies quite a bit. Guys will only get a small piece of the pie here. I hate to tell you, but we just don't use androgens nearly as much as we use estrogens out there in the world. But androgens are important. What are the kind of most important ones? So dihydrotestosterone and then testosterone itself. Those are probably the two of the big ones. We're going to see kind of the most activity of at least endogenous, naturally acting sort of hormones. And again, we remember, you guys remember what enzyme converts, aromatase converts into what? Yeah, it turns it into estrogens. Aromatase is important for converting products into estrogen. What converts testosterone into DHT? Yeah, remember there's a 5-alpha reductase. So we'll look at some ways that we can kind of mess with that. When we'll talk about this more when we get to the urology section, especially when we're talking about things like erectile dysfunction and BPH. So that'll come up a little bit later in the urology section. So just be aware some of those drugs will show up there. But we'll kind of briefly talk about testosterone replacement here. But again, we know it's made in the testes. It's kind of the primary thing we're going to see produced there is testosterone, and that will get converted out in peripheral tissues by that 5-alpha reductase. And again, DHT is going to be much more potent than you would see with testosterone by itself. Again, some of that will get converted into estradiol via aromatase, which is what happens when you gave aromatase inhibitors to female patients. So you saw menopausal symptoms from a lack of estrogen. What was the other thing you saw? You have osteoporosis. We also saw kind of masculinizing sort of effects, right? Because again, you're blocking that conversion, so you're going to have more testosterone having been produced there, right? So that was the kind of a risk that you see things like hirsutism, voice changes, things like that. Other big thing to note is that these are going to be metabolized in the liver. So this is why we do not like to give oral testosterone replacements, because they are very, very hard in the liver, very likely to cause hepatitis and hepatotoxicity. So we really like to avoid a lot of those. Oftentimes, what other routes can we use instead? Injection is a big one. Anything else? There's some topical applications we can use as well. So there's lots of different forms that are out there. There's kind of gels you can administer, but a lot of them are going to be injections. Some of them are going to be like depot injections, where they'll be compounded on kind of an oily base. They'll be injected into the muscle that can be slowly released over time. What kind of patients do you think could benefit from that? So I'd like Arnold Schwarzenegger. He probably benefited from it at some point. Okay, so hypogonadism, right? So that could be one where they could benefit because if they're not producing enough of their own testosterone, we can replace that. Anything else? Yeah, they have a growth hormone deficiency. They're not, again, producing a lot of their own testosterone. It's a big thing there. What kind of other medical conditions, maybe not related specifically to the body's ability to produce testosterone? I'm trying to think of a better way to. Sure, for chemical castration, you certainly shut down a lot of production. Because again, one of the things you see when you provide exogenous testosterone, what does that normally do to testosterone production in the testes? Should shut it down, right? Because again, it's that negative feedback loop being inhibited. If it senses it has enough testosterone around, it'll shut down production. So normally you see testicular atrophy associated with that. Well, the thing I was trying to get at, which again, shame on you for not reading my mind. I guess our ESPN is not that strong. Basically, you can see it's in a lot of wasting conditions. You have things like late-stage AIDS patients. You have patients who are on chemotherapy who are kind of wasting away. This is good because we know that testosterone is an anabolic hormone. It helps to put back on muscle mass. It helps to utilize amino acids coming through the diet to put that muscle mass back on. And we know that these patients tend to lose a lot of muscle mass as they get older. So also there's a lot of effects of libido and things like that. But those are some things to consider. The type of patients may benefit from testosterone. What could testosterone be bad for? What type of conditions? Yes, sir. It certainly can worsen that. Yeah, prostate cancer, that's the other big thing, right? So it helps to stimulate the prostate to grow. So, if you had a patient with BPH or they had a history of prostate cancer, that could be potentially worse. So kind of think about those kind of physiologic effects there. Very similar to what we were thinking about with like the estrogens and how those were affecting on different sites in the body. But anyway, we know that normally we have the hypothalamus producing gonadotropin releasing hormone that will stimulate the pituitary to produce LH and FSH, and then that helps to stimulate the testes to make testosterone. Again, when we're giving exogenous testosterone, that should shut down the system. You'll see decrease in activity of LH and FSH being released and decrease in G and RH activity. Okay. Let's see. And it's locking up again. There we go. All right. So several different types that are available. Usually what you're going to find is that these will be available in different kind of salt formations. Basically, we have the naturally occurring testosterone, and you'll find lots of different formulations that are available out there. So things like Androgel, Depo-Andro. Has a Depo in the name. That tells you what? Probably going to be an injectable product. It's going to be an intramuscular product. It will have a long duration of action because we'll be releasing that drug slowly over time. Androgel is probably what type of dosage form? Probably a gel. Anyone know where you apply that to?
Arm, actually.
You can do the arm. Yeah, it's usually one somewhere where it's going to have good absorption. So the more occlusive you can get, like maybe a little bit more better absorption you can have there, right? So anyway, so there's lots of different forms. There's some that are going to be implantable products you can have as well, similar to what we saw with some of the female hormones. And then certainly there's dihydrotestosterone. We're going to find that this in high amounts can worsen things like BPH. And so we'll have some drugs that will actually work by inhibiting 5-alpha reductase. So we can decrease the amount of DHT that actually gets produced. And we'll talk about that more in BPH a little bit later on in this class. Now, we certainly have some synthetic forms we can administer, and this is not an all-exhaustive list, but these ones are going to be either alkylated forms or esters of testosterone. So you have things like methyl testosterone, which is PO. You have fluoxymestrone. You have oxandrolone. And again, these are tough on the liver. So again, we don't like to use oral administered androgens if at all possible because of the hepatic effects. Similar to what we saw, what kind of hepatic effects do you see with like estrogens in female patients? Things like birth control. Clotting was an issue, right, because they're producing more clotting factors. What else? You see cholecystitis associated with that, right, because they're getting metabolized there. Same thing's happening here, where again you're seeing a lot of metabolism of the androgens in the liver that can cause hepatotoxicity. So just be aware of that. So again, typically looking at the physiologic effects, we'll see that with androgen being mediated through both testosterone and DHT receptors here, we're going to find that, certainly development things like skeletal muscle, erythropoiesis is another big thing. So you may see, especially testosterone being used from like a blood doping sort of standpoint to increase activity or a function of erythropoiesis. Certainly with DHT is where we think a lot of like the male pattern baldness and things like that come from is kind of increased activity there affecting the hair follicles. And then remember that when you give androgens, some portion of that will also get converted into estrogen, estradiol, by aromatase. So there are going to be some effects from that. So you can have effects on growth plate closure. You can have libido being affected here. So just remember there's going to be some ancillary estrogen side effects that go along anytime you give testosterone. So some of the other therapeutic uses, male infertility. Sometimes we can use testosterone, like a methyl testosterone. Is kind of what we're referring to there. You'll also gonadal function, so I kind of mentioned that. Osteoporosis, because you can have some positive effects on the bone by increasing testosterone activity. Let's see. Inoperable breast cancer, so fluoxymestrin has been used for that occasionally. Let's see. And then, as I mentioned here, offset weight loss due to kind of wasting syndromes like burns, trauma, any kind of chronic illnesses. I've seen that used for that as well. So that could be lots of different causes for that. And the anti-androgens, things that are blocking the activity of testosterone, things like metastatic prostate cancer, treatment of hirsutism in women, if they're having kind of a hyper-androgenic sort of state, you can help to block that with anti-androgens. So, as I mentioned, orally, typically they get metabolized readily in the liver, so they're not super useful for oral administration. That's why we have things like the alkylated forms. We have forms that we can modify in order to allow to bypass the liver, or not to bypass it, but to get through the liver with only kind of limited first pass effects there. So that's where you have like methyl testosterone. More often than not, they're going to see injections where you have like testosterones and oil bases against like depo-testosterone, and then some transdermal forms as well. It's like testoderm, androderm. So there's lots of different formulations that are out there. They're all probably just slightly different from one another. Okay, and then looking at the anti-androgens, so these are going to be androgen receptor antagonists. So you have things like flutamide, bicalutamide. So who do you think might utilize that? And prostate cancer is probably going to be a big one. What type of side effects do you expect to see from that? Maybe some gynecomastia, maybe see like an increase in estrogen activity. So those are all things to kind of consider. Remember that spironolactone has some mixed activities here as well. Remember how spironolactone for females can actually have some increased androgen sort of effects. It's a partial agonist, so you can see things like hirsutism associated with that. However, for like guys, it may actually act as a partial agonist to decrease activity, so you can actually see things like gynecomastia develop from that, right? So remember, the spironolactone, that was a big side effect that was bad for male patients, was the gynecomastia associated. You have cyproterone, which can be a mixed progestin receptor agonist and androgen receptor antagonist. Again, you find some kind of specific use cases for these, which I'm not going to get super in depth on. But we'll also have our 5-alpha reductase inhibitors, and these are going to be used very frequently for BPH, which we'll talk to that in the urology section later on. Things like finasteride, dutasteride are going to be really important here. Okay, so I mentioned our side effects with the androgens. You see a lot of prostatic enlargement, prostate cancer being a risk, obviously that's a big one. Testicular atrophy, because again, as you activate that negative feedback loop, you're going to be shutting down FH and LSH production, which is going to decrease sperm production there. So you should see infertility associated with that as a potential side effect. Worsened acne can be associated with this. You always think about patients who are on testosterone products and develop what we call bacne. Can be kind of pretty significant amount of back acne can form there. Gynecomastia associated with that, and then especially for patients who are kind of chronic illnesses, you think like end-stage cancer patients, AIDS patients, you can see some erythrocytosis may be beneficial for them to kind of help stimulate erythropoiesis, but it shouldn't be a problem in most patients. Certainly we'll see some increased sodium and water retention, so you may see that being an issue for patients with CHF. Monitor for that. And then I mentioned the issues with the liver. So again, watch out for oral administration. You will see some hard effects on the liver from that standpoint. And obviously the masculinization effect in female patients. Okay. So as I mentioned, some things we can do to try to interrupt this cycle here. Things like to treat, we'll talk about these just briefly here, but DHT inhibitors. So basically by inhibiting 5-alpha reductase, you prevent conversion of testosterone to DHT. This is where you have things like finasteride and dutasteride. These are especially teratogenic. So actually we recommend, especially for patients who are in the hospital, especially female patients, not even handling these drugs without gloves, because of the fact that if they had any effect on a growing fetus, especially testosterone and other hormones being really important there, you can actually see a lot of teratogenesis associated with that. And then we also have our GnRH analogs, and so again, these are going to be things that help to lower testosterone production by activating that negative feedback loop, essentially by kind of shutting down production of LH and FSH. This is where we have things like leuprolide and goserelin. These can, depending on the dose, can either shut down kind of the whole axis, or they can help to stimulate it, and depending on the dose. So there's kind of multiple uses for it, depending on what the indication is. Imagine here, GnRH antagonists, can be usually will have kind of a negative effect here, but GnRH agonists, as I mentioned in the last slide, there can either have some positive effects depending on the dose you're giving, or it can help shut down the whole system based on kind of negative feedback inhibition. Let's see. Any questions on the androgens? Again, sorry guys, it's such short-lived, but there's not a whole lot to talk about. I don't use them nearly as much as the estrogens, so I like to focus on that quite a bit. I mean, you can reschedule someone's menses. I mean, how amazing is that with those drugs? Incredible. Guys like, okay, get a little bit bigger. What's the big deal, you know? Anyway, adrenocortical insufficiency. So, where can we see this? Who might have adrenocortical insufficiency? Cushing syndrome, okay. Addison, anything else? There's some patients here, especially like pediatric patients who've had certain cancers, may have had to have tumors removed and things like that. Can have some issues here where they've kind of screwed up kind of their whole adrenal axis. Basically, what we're going to see is we're going to have drugs will have activity at glucocorticoid receptors and some at mineralocorticoid receptors. Remember, think aldosterone as being our primary mineralocorticoid, and based on that name, what do you think it's mainly doing? Mineralocorticoid. Mineral, I think salt, I think holding on to salt, you think holding on to water, right? So that's going to be really important for regulating blood pressure control, regulating blood pressure by regulating blood volume. Keep that in mind. We already know what glucocorticoids do. We know they're potent in anti-inflammatories. We know our major one that we produce is cortisol, but certainly we can supplement that with lots of exogenous hormones. Now, just remember here that normally, cortisol, which another name for it is hydrocortisone. So when you think of like hydrocortisone cream, that's basically what we're producing already. Just a different name for the same thing. Notice here that, we have things like increased stress will increase release. That can be important. We'll have some patients who have, adrenal insufficiency, who, especially when they get stressed out, they can't really respond to that so well, and they end up having to come into the hospital because they have, basically insufficient amounts of hormones that they're actually producing themselves. We'll look at some ways we can help to replace that. But in general, this is what we're trying to mimic the effects of when we're trying to replace this. So you think things like chronic, like Addison's disease, hypotension, weight loss, a lot of fatigue associated with this, and a lot of glucose kind of intolerability. So you may see hypoglycemia associated with this. And so, what we'll see in some of these patients, they can develop, circulatory shock and eventually death, based on the fact they can't really regulate their blood pressure so well. It's kind of one of the big issues we run into. We see this in the ER with some regularity. We actually had this one patient who always comes in with these adrenal crises where, very hypotensive, ultra mental status, and we have to give them big doses of corticosteroids in order to help replace that essentially and try to get things back on track. Give them lots of fluids, replace the hydrocortisone they're not producing themselves, and kind of get them back on track. So that's one thing we'll see with some regularity there. And so what they'll do is they'll take, a standard daily dose of the hydrocortisone, say 20 to 30 milligrams a day, to replace what their body would have produced, their adrenal glands would produce. And we'll actually have to give them stress dosing instructions. So they'll say, okay, well, if you get sick or if something like this happens, this is where you take, say, an extra tablet a day for how many ever days. And they don't do that, and that's where they can run into some of these crises where they end up, coming into the ER. They may also be on something that is going to have primarily just mineralocorticoid effects, and so this is a new one called fludrocortisone, or Florinef is another name for that. And so this one is specifically working to help to retain salt and water, and so this helps to maintain their blood pressure a lot better. Certainly, hydrocortisone has some glucocorticoid action, some mineralocorticoids, kind of a mixed balance between there. But fludrocortisone is primarily just a mineralocorticoid, and it will help with fluid and salt retention. Okay. Next up, we'll talk about the thyroid real quick. Any questions so far? I'm kind of going through these quick, but I'm just kind of mentioning kind of new drugs as we go, talk about them briefly. But if you have any questions, feel free to stop me in the meantime. Anyway, so the thyroid. So, what are some problems with the thyroid? We either have hyperfunction, right, hypersecretion, or we can have hyposecretion, hypothyroidism. And so we're going to find that ways we can replace that, ways we can help to stimulate production. Anyone know what the primary drug we get for hypothyroidism is? So Synthroid, levothyroxine. All right, so we'll talk about that in some detail here in a second. So basically, and you guys have covered this already, talked about this. Okay, so there's kind of different places where the issue is going to be, whether it's say primary destruction of the gland itself, say it's a secondary issue with like the tropic hormone or the hypothalamic hormone. We'll see there's different places where we can affect this, and we talked about negative feedback loops, so you guys are pretty well familiarized with this. And again, if you have hyposecretion, obviously the thing we can do is try to replace the hormone that the person will be supplying themselves, right? So we can replace that. It's pretty easy. The hypersecretion though is going to be a different story. We'll find that there's a few different drugs we can use to help deal with that. In some cases, what do you have to do if you have a hypersecretion? Take the whole gland out, right? So again, we'll find, hopefully we don't have to get to that point. We'll have some drugs that can kind of help to deal with that. So what metal is super important for producing thyroid hormone? Iodine, good. Does anyone know it gets produced in high amounts if they're, say, for instance, this is a weird tangent, but when I learned this stuff in school, I had to go off this weird tangent with a teacher, so I'm going to give it to you guys as well. If there was a nuclear blast that occurred, which unfortunately is more real today than it was maybe last year, what's one of the big problems with that? Say you're outside the blast zone, you're not immediately exposed to that stuff. Anyone know what kind of radioactive elements get produced? Iodine. There's actually radioactive iodine that gets produced there. It's weird that I was taking down that road and you jumped to that conclusion. But yes, radioactive iodine is a big deal. And so the problem is that radioactive iodine will get taken up into the thyroid, just like regular iodine, and you can actually develop cancers related to that. So that's actually one of the big concerns, and why if you get like a bug out bag or like a survival kit, which I suggest everyone buy into, should have available at your house. You never know when nuclear disaster is going to hit, right? Maybe not, but they usually have iodine tablets associated with that, because if you're intaking enough iodine of your own, it helps to prevent you uptaking this radioactive iodine, and you can survive for longer. So, random fact, but true. Anywho, so anyway, we see the hypothalamus again secreting thyrotropin releasing hormone onto the anterior pituitary, releasing thyroid stimulating hormone, which will then stimulate the thyroid to release. What do we release from the thyroid hormone or thyroid gland? It's T3 and there's T4. Those are the two primary components we're going to be looking at. Remember which one's more active? T3 is a more active form, right? Not the best Terminator movie, but it is a more active form than T4. I think arguably it was a worse Terminator movie than T3. So just think about that, right? T3 is going to be the more active form of thyroid hormone. So basically what's happening here, we're seeing the iodines coming into, and again, I'm not going into super detail on this, but just know that iodine is an important component of this. Iodine is necessary to produce thyroid hormone. What happens if you have too much iodine? Too much iodine can actually shut down this process. It can actually help to stunt further production of thyroid hormone. So it kind of has a double-edged sword. You need the right amount to stimulate thyroid hormone production, but too much of a good thing can shut down production here. So remember that. We'll get a few examples of that in just a little bit here. But basically, you're going to see the iodine is going to come in, and we'll get this process called organification, where it will get converted into some of these kind of intermediary products, where it basically gets converted with thyroglobulin and tyrosine into, it's either this monoiodotyrosine or diiodotyrosine. Those end up getting connected together, and I'll show you a picture in a second, to either form T3 or T4. Once those are formed, then they can be released out into the bloodstream, and you'll have things that will be able to convert T4 into T3 eventually for its metabolic purposes. T4 has some activity, but not a ton. Most of it has to get converted over to T3. Okay. So again, just the different steps here. The iodide trapping, where it's going to be coming into the follicular cells, and eventually it gets organified along with tyrosine, and that's where you're going to have that monoiodotyrosine and diiodotyrosine, and they will come together. And if you have two diiodotyrosines, what do you get? If you had to guess, 2-di T4, right? If you get a mono and a di together, you get T3. Absolutely, good. You guys are way ahead of the game. Anyway, that's how it works. Two diiodotyrosines come together, get T4. One iodo or monoiodo and one diodo will come together and get T3. So essentially, what you can find here is that this process can be blocked by high levels of iodide. So that's why I was mentioning if you had a nuclear blast and you're surviving in the fallout of, you would see that taking the iodine can actually help to blunt this, and it will prevent uptake of that radioactive iodine, where you prevent thyroid cancer from happening. But basically, once that ends up getting released, you're going to have T3, T4 being produced. Usually it's about a ratio of 5:1 of T4 to T3. That then gets released out into the bloodstream. T3 can be active immediately. T4 will have to get converted over. So again, all right. So again, once the bound TH thyroid hormone crosses the apical membrane, it undergoes that proteolysis, where the thyroglobulin will be relieved there. And again, this is another step that will be blocked by high levels of iodide. So again, too much iodide can be a big problem and kind of shut down this whole process here. So anyway, so again, T3, 3 to 4 times more potent than T4, as we've already kind of mentioned here. T4 is kind of considered like a pro-hormone, and this will be important when we're looking at the different drug formulations that we give. Because anyone know, Synthroid we mentioned is the main drug we're giving. Anyone know what that is more related to, T3 or T4? You think 3, but it's actually T4. So we'll see why that's important here in just a little bit. Anyway, and again, that process here of converting T4 to T3 can also be blocked by iodide. So there's also reverse T3, which is actually inactive, so we're not going to talk about that too much, but just know that T3 is going to be the primary one we're focused on for our metabolic effects. Here's an example of thyroxine. Here's T4, and then if you were to have you have one step of actually producing normal T3, and then you have this kind of inactive form, which is reverse T3. But just know this is the main one we're kind of looking for activity from. Okay, so looking at thyroid replacement agents, so again, this would be for patients with hypothyroidism. Certainly we can give levothyroxine. This is basically T4, levothyroid, Synthroid. Synthroid is probably the more common name you guys are somewhat familiar with. This is going to be the drug of choice. The problem is, how fast do you think it works? Is it super fast acting, slow acting? Pretty slow acting. That makes sense, because if you guys cover like how you monitor someone with hypothyroidism. Yeah, so so every 3 months, right? So you're monitoring their TSH, you're monitoring things like T3 levels, but it's every 3 months. This takes a long time. This is not a very quick process to fix this. And again, that's fine because the drug we're giving is not super fast acting in the first place. So we can give T4. And so we have parenteral forms that are available, we have oral forms that are available. What's kind of interesting is, anyone ever been around someone who has been declared brain dead and is going to have their organs harvested? Anyone ever been worked with trans life? If you get an opportunity to talk to a trans life person, do it. It's a very, very cool kind of process. It's very sad for the person, but they're giving the gift of life to others. So there's some benefits there. But if you like working in ICU or something like that, you'll maybe have an opportunity. But it's really cool, the kind of the plethora of drugs they end up giving these patients, because again, when you're brain dead, like, you basically have all kinds of physiologic activity kind of goes out the window, and so we have to replace a lot of things. We have to replace hormones, there are glucocorticoids, we have to replace levothyroxine, we have to do all these different things to try to keep the body still running, essentially, for when they have the chance to harvest the organs and send them off to wherever they're going. So again, I would recommend if you get a chance to talk to some trans life people. Anywho, but yeah, most of the time this will be an orally administered drug. Big things to know as far as like food interactions, drug interactions. You have to separate the Synthroid out from a lot of things, because iron, calcium, aluminum will all impair absorption. So again, it's one of those things where you don't know if the patient is not getting enough T4, or is it the problem that they're not absorbing enough T4, right? So again, a lot of it goes back to food-drug interactions there. I'm just going to finish this section up real quick. Is that okay? Don't fight me too bad. You have lunch after this? I'm sorry. I'm getting death stares. Anyway, there's liothyronine, which is T3. This would actually be a faster acting form, but we're going to find that it has a lot higher cost associated and it requires a lot more frequent dosing. The half-life is a lot shorter than you see with T4, so this one we don't give as often, but Synthroid is probably the more common one you're going to see used administered. There's another one called Liotrix, which is actually a ratio. This is more kind of natural to what a body normally produces. However, again, more expensive, don't release that frequently. So think Synthroid, think hormone replacement. And again, you can use it for lots of different things if someone's had a subtotal thyroidectomy or Hashimoto's, mixed edema, or potentially if they have radioiodine ablation of the thyroid. Because again, we can actually ablate the thyroid by using radioactive iodine. We can replace it by using things like Synthroid. Okay, I'm going to go ahead and cut it there so that way you guys don't yell at me. Oh, I have 6 slides left. Let me finish though, 6 slides. You guys will be fine. I'm sorry. Anyway, so again, note these are hormones that are working at the site of the nucleus, right? So they take time to kick in. Some of the glucocorticoids are slower to act than something like an NSAID or something like that, right? So again, it takes time for them to kick in. Anti-thyroid drugs, right? We have 2 main ones here. We're going to have PTU, propylthiouracil. How this one's usually abbreviated. And we have methimazole, and basically what these are doing is helps to block conversion of T4 over to T3, and will help to block production of the thyroid hormone. So again, if you have someone who has hyperthyroidism, this can be given in order to help block production of that, and will help to kind of get their levels back in range there. A risk of agranulocytosis, so again, watch for their blood counts, do it at baseline, do it follow-ups, kind of see what they're kind of monitor for things like infection and things like that. Okay. Blah blah blah. You can read the mechanism here, but basically they're preventing kind of those different steps of the thyroid hormone production process there. They kind of interfere with that organification. But the major place we're using this would be for things like Graves' disease, or if they have goiter. These can be good because they will actually help to shrink down the thyroid prior to surgery and kind of have it a little bit easier to resect for those instances. So this might be something patients are on kind of long term. They have kind of chronic hyperthyroidism. Okay, let's see. So again, you can use radioactive iodine. Sometimes this is useful for helping to ablate the thyroid gland. This will be used occasionally where basically give this radioactive form. It will emit gamma rays and beta particles. Basically, it'll get uptaken preferentially into the thyroid, irradiate that area, and they'll basically destroy the tissue. So again, that's another concern you're worried about when you have something like a nuclear blast that went off, right? Okay, and again, you're gonna have a big incidence of delayed hypothyroidism. That makes sense because you're basically destroying that tissue there. Small risk you may turn into the Hulk because of the gamma particles, but very, very unlikely to occur. Anyway, and then one last group here, we have the saturated iodide solution. So these are very concentrated forms of iodine that we can administer to the patients. This helps to shut down production of thyroid hormone, good for hyperthyroidism due to the high mass. We said too much iodide can be a bad thing for the thyroid and will shut down production there. So a couple different solutions there. Big thing to worry about the iodism. When you have too much iodide, you see a lot of rash, swollen salivary glands, so you can see that occasionally. Okay. This ipodate is just, you'll find a lot of iodine in contrast procedures. This is one that can be normally used for contrasting uses, but can sometimes be used for thyroid storm as well. It's covered thyroid storm. That's thyrotoxic crisis, so this can actually be useful because it helps to inhibit conversion of T4 to T3. So it's kind of an off-label use, but you may see that used occasionally. Okay, sorry about that. I went over a few minutes. Please don't kill me. Anyway, any questions? All right, we'll have our review Thursday, I think. See you then.